Healthcare Commission meeting. This meeting is a hybrid commission meeting. There are several commissioners, actually 2 commissioners in room 100, and the rest of the commissioners are participating via Zoom. I want to thank Commissioner Jensen for not having me too lonely here all by myself. Although I do have this most excellent staff. Given that this is a hybrid meeting, additional ground rules will still apply. I will begin this meeting with a roll call of commissioners. During the meeting, I'll ask the commissioners and presenters identify themselves before speaking, so that the commissioners and members of the public will know who is talking and have the same knowledge as those who are in room 100. All commissioners are unmuted and may speak. Public and most staff should self-mute and may not speak unless recognized by the chair. Due to the possibility of background noise, I ask the commissioners and presenters to mute their electronic devices when they're not speaking. And I ask commissioners attending remotely to avoid putting substantive comments in the chat, as that can be difficult for those of us in the room to see. As previously stated, the MHCC posts documents that will be acted on or discussed at least a day in advance, so that members of the public will have time to download them before the meeting begins. We will continue to provide advance notice of how to register for and dial into the meeting by posting that information on the homepage of the Commission's website and on our various social media channels. Now it's time to call the roll. Start with Commissioner Bhandari, who, welcome, sir, I can see you. And Commissioner Boyer, who I can also see, welcome. And Commissioner Boyle, welcome.
Hi.
And Commissioner Brumbaugh. I did not see Commissioner Brumbaugh. Commissioner Buzinski.
Here.
Commissioner Cheatham.
Here.
Commissioner Jordan.
Here.
I see Commissioner Jensen. Here. Commissioner Metz.
Here.
Welcome. Commissioner O'Connor.
Here.
Commissioner O'Grady.
Here.
On the TV. Commissioner Ojikutu. Commissioner Wang.
Here.
And Commissioner Wood. I can see Commissioner Wood.
Here.
Welcome. So I'll ask Commissioner Brumbaugh, just to give him a chance. Commissioner Ojikutu. Nope, we have a quorum though, and we can proceed. All right, so agenda item number 1 is the minutes. Included in your packets are copies of the minutes for the November 17th, 2022 public meeting of the commission that took place in person and by video conference. I will now entertain a motion to approve the minutes of that meeting. Do I have a motion to approve the November 17th minutes?
So moved.
Mr. Jensen
Second.
and Commissioner Boyle, I think, did a second there.
Yeah.
In which case,
Let's get him set up with chicken before you leave, because if not, I'm gonna stress myself. Just to buy you that little top plate right there.
I'm sorry.
Wood, you're on.
Sorry about that.
Oh, it's quite all right. So, does anybody want to discuss the minutes? In that sense, all in favor of accepting the minutes?
Hi.
Are there any opposed?
Aye.
Great, none opposed. Agenda item number 2. Commissioners have received the written updates from our centers. Commissioners, do you have any questions on the written updates? Nope.
I'll just point out the my usual that the majority of nursing homes that are coming in and purchasing, that are coming in from out of state to purchase nursing homes have poor ratings and would not qualify for a CON. Just to continue the thought that this is a problem.
Thank you. Are there any other comments or questions? If not, Eileen Fleck, I understand that you want to introduce a new employee.
Thank you. Katie Nayrol is joining MHCC as a program manager at my division. She has spent more than 20 years working in service to Maryland Medicaid, including working in group homes at Kennedy Krieger's Neurobehavioral Unit and at Johns Hopkins Bayview. She also spent almost 10 years as a supports planner for a home and community-based waiver. Her state service began in 2016 in Medicaid policy. As a program manager in my division, she'll be working on state health plan chapters and also certificates of ongoing performance for cardiac surgery and PCI programs. Please welcome her.
Welcome, Katie. To say that now for the executive director, Ben, if you have any updates.
Thank you, Sheriff Sergeant. Looking at our agenda today, I have a lengthy update, but I'm actually going to cut it short, and I'll share some of that at the conclusion of the meeting. The material I'm going to defer right now mostly pertains to the work of about a half dozen work groups. I'll brief you at the conclusion, but I did want to make sure the commissioners know that the legislative reports that are due for December are either being submitted, or very close to being submitted. They include, as you know, our telehealth report and recommendations. You heard a presentation on that in November. David Sharp's going to be back to present a brief summary of some additional changes we made as a result of input from stakeholders. We have a joint chairman's report, obligation to report on the existence, if any, of financial restrictions that limit access to organ transplants. Eileen Fleck will present that report to you today, and with your approval, we'll send that to the legislature. We have 3 mandate studies that are due. You heard one on changing co-pays for physical therapy last month. We have one today covering expansion of the vitro fertilization benefit, and with your approval, those 2 then to the legislature later this month. The third regarding test kits for sexually transmitted infections. We've decided to defer that until January, which is technically after the date that it's due, but it's our expectation is that it will still meet the needs of the legislature. And so that is our plan for that report. In addition to that, an annual report that we do on the trauma system has been completed and will be presented to you today. And after approval, it will be sent to the legislature. I do want to thank all of the staff for the work over the last couple months. And some staff had to jump in pretty quickly because frankly, I missed the directive to do the study on financial restrictions, if any, organ transplants. I think that's an issue that will crop up again in this session. So we got that done. I want to thank you, Eileen and others who worked on that to jump in late September to carry that out. So thank you, everyone. And I'll talk briefly about the work groups at the conclusion of the meeting.
Thank you, Ben. That we'll move into the body. Before we consider action items today, I want to remind commissioners if they wish to recuse themselves on any action item, they should inform the chair and state their recusal on the record when the agenda item is announced. Commissioners who are remote who desire to recuse should remain silent and turn off their cameras and mute their phones. Commissioners here in room 100 will leave and move to the small conference room. Turning to item number 3. State law required MHCC to develop a state recognition program for electronic advanced directive services. COMAR 102519 outlines the state recognition process. State recognition is a prerequisite for connecting to the state designated HIE. Legislation passed during the 2022 session repealed a requirement that vendors implement a National Institute of Standards and Technology defined user electronic authentication standard. Justine Springer, Program Manager, Health Information Technology, will present on the proposed change. Justine, you have the floor.
Thank you, Mr. Chairman. Next slide, please. An advance directive outlines a person's wishes if they are incapacitated or unable to express wishes for healthcare and treatments. Increasing creation and accessibility to electronic advance directives has been a focus in Maryland since 2011, when the Office of the National Coordinator for Health Information Technology, or ONC, awarded MHCC a grant of roughly $1.6 million to explore options to facilitate availability of electronic advance directives. ONC is the principal federal entity charged with coordination of nationwide efforts to implement health information technology and the electronic exchange of health information. In 2012, staff convened a stakeholder work group to deliberate on technical and policy matters related to electronic advance directives, as well as the medical orders for life-sustaining treatment form. The work group concluded that advanced directives available through the State Designated Health Information Exchange, or CRISP, was a viable means to securely communicate individual preferences about end-of-life care. Next slide, please. In 2013, staff issued a request for proposals to identify a vendor that could implement an electronic advance directive system statewide that healthcare providers could access at the point of care through CRISP. AD Vault Incorporated, doing business as mydirectives.com, was competitively selected to build an interface between its cloud-based advanced directive service and CRISP. The interface was launched in the summer of 2014. Over the next 3 years, the General Assembly passed various bills that aim to support greater diffusion of electronic advance directives. Next slide, please. Some notable aspects of the law include alterations to witness requirements, expansion of outreach and education initiatives, development of a state recognition program for electronic advance directive service, and the establishment of an advance directives fund. Next slide, please. In 2016, staff identified technical and privacy and security policy considerations in collaboration with stakeholders to inform development of an MHCC state recognition program for vendors offering electronic advance directive services. State recognition demonstrates vendors meet industry standards and best practices related to privacy and security, among other things. COMAR 1025-19 overviews program procedures for vendors that seek state recognition, a requirement for vendors to integrate their solution with CRISP. This includes processes for developing vendor criteria, which consists of standards for privacy and security, auditing compliance, consumer education, reporting, and technical provisions. Next slide, please. Legislation passed in the last session removes the requirement for vendors to implement identity proofing standard published by the National Institute of Standards and Technology, or NIST. This requirement was generally viewed as burdensome for consumers and vendors, as other standards exist that are more nimble and just as effective. Removing this requirement in the regulation may lead to more vendors seeking state recognition. Next slide, please. A notice of proposed action was published in the September 23rd issue of the Maryland Register for a 30-day public comment period. Amendments aligned to the law, removing the NIST requirement from Regulation 02 definitions, and no comments were received. Next slide, please. Draft updates to vendor criteria for state recognition were published in the Maryland Register on August 26, 2022, and on MHCC's website. The criteria remove the NIST requirement, among other changes, which include clarifying supporting documentation for privacy and security controls through accreditation or certifications from a nationally recognized organization, and modifying vendor reporting to MHCC from biannually to quarterly. No comments were received. Slide, please. Staff recommends the commission approve the amendments to COMAR 1025-19, and the vendor criteria for state recognition is final. That concludes my presentation, and I'm happy to answer any questions.
Great. I'll start with, do I have a motion to adopt Kumar 10/25/19 state recognition of an electronic advanced directive services, final regulations of the commission. Move Commissioner Jensen. Do I have a second?
Second.
O'Connor.
Krasinski, I believe, is the winner on the second. Do any commissioners have any questions or discussion?
I do.
Commissioner Grady?
Yeah, I don't mean to be the skunk at the picnic, but the last time we presented on this, I went out and went to register my advanced directive. And the main part of the program goes fine, but when you get to the end to verify, that it's really you, it was very, what should we say, not user friendly. I gave up after an hour, and I'm fairly facile at these things. And so I do not have a registered advanced directive with the state of Maryland because the user interface I'm not even sure it was, I may have already been out of CRISP by that point, may have been a secondary vendor, but there was no way I could get it no matter what they kept asking me for verifications. And I don't know how many other people had a similar thing. Maybe it was a bad day with the software, but I thought I should at least tell you, and I would encourage the other commissioners to go ahead and try it and see if they can do it in a reasonable amount of time.
So that is part of the NIST requirement that we repealed in law and that is now going to be taken out of the regulations. So that it does speak to that it was burdensome for consumers as well as to vendors. So thank you for.
But that hopefully will improve. It's a good example of why we're doing this. Thank you.
Sure.
So I think Commissioner O'Grady's suggestion though is a good one. So if any commissioners want to try mydirectives.com right now, that's the only advanced directive vendor that has been certified by MHCC, but it's mydirectives.com. You can leave a.
I'll try again. Maybe I caught them on a bad day.
No, I think you absolutely hit the nail on the head, Commissioner O'Grady, that has been a major complaint of the current arrangement. They were in mydirectives.com's defense, they were conforming to the Maryland law that required this level authentication to get access. So we've eliminated that, not yet, as they said on Seinfeld, you're not free yet, but with this change, it will be soon. We will communicate that instruction as well as your perspective, which I think my directives has probably heard multiple times, but we'll emphasize that as well. Thank you.
Great, thank you.
And with that, to make this change final, can I get all in favor of adopting the passing motion?
Aye.
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 Are there any commissioners opposed? Excellent. Have your final regulation. Agenda item number 4. It's a certificate of need application filed by the Board of Child Care of the United Methodist Church, Inc., Baltimore County. So the certificate of need CON application filed by the Board of Child Care to renovate an existing cottage on its campus to house a 4-bed residential treatment center in Windsor Mill, Maryland, Baltimore County. Jean Marie Gowell, CON analyst, present staff recommendation. Jean Marie, please proceed.
Good afternoon, commissioners. The Board of Child Care is a private nonprofit located in Windsor Mill, Maryland, in Baltimore County. The Board of Child Care provides services throughout the Mid-Atlantic and is licensed to operate 6 group homes in Maryland, as well as 4 outpatient centers for community-based programs. The applicant currently provides programs for high-intensity group homes, treatment foster care, and is home to the Strawbridge School. Regarding this project, Maryland Children's Cabinet and the Maryland Department of Health identified a need to support youth experiencing extended and repetitive psychiatric stays in hospitals. In July 2021, Maryland Department of Health released a notice of funding availability to support the development of a program to meet the needs of this overstay youth population. For example, between January 2020 and July of 2021, the Maryland Department of Human Services reported a total of 628 youth hospitalized in Maryland for psychiatric care. And 84 or 13% of those hospitalized became overstay youth, which is defined as more than 24 hours in the hospital. The Board of Child Care responded to the notice of funding eligibility with a program proposed to address this crisis entitled the Bridge Residential Treatment Program, or BRIDGE program. The BRIDGE program will provide stabilization services for youth upon discharge from the hospital. The applicant is proposing to obtain licensure as a 4-bed residential treatment center, or RTC, to be housed in an existing cottage that exists on the Baltimore campus. The applicant states that approximately 2,967 square feet of interior space and 900 feet of exterior space will need to be renovated for the project. In Maryland regulation, an RTC is a psychiatric institution that provides campus-based, intensive, and extensive treatment of children and adolescents with severe and chronic emotional disabilities who require self-contained therapeutic, educational, and recreational program in a residential setting. There are currently 6 RTCs that operate in Maryland. This program will serve youth needing psychiatric care who have co-occurring behavioral and medical needs. Board of Child Care will provide services to both male and female youth ages 14 to 20 years old. The BRIDGE program will also provide placement support services. The proposed project has a total estimated cost of $922,238, and the financing is a grant from the Maryland Department of Health. Regarding need, the applicant demonstrated that the project will be able to meet the needs of the current overstay youth population in Maryland hospitals. Because need is strongly demonstrated by the creation of the grant itself, it also follows that the impact of the project will be positive for the healthcare delivery system and will not negatively impact current RTC providers, as they are not currently serving this population due mostly to the high costs associated with caring for them, which are mostly due to staffing costs. Regarding viability, as the applicant is a nonprofit, it will have access both to the funds from the grant and additional funding from fundraisers. There is no debt financing needed for the project. The project has support from the Maryland Department of Health, the Maryland State Department of Education, and the Governor's Office for Children. In conclusion, based on the review of the proposed project's compliance with the certificate of need review criteria.
I have to do it on my phone.
Yeah, you're gonna set that up if you're dealing with the do it thing, the login.md.gov.
So, commission staff.
No, I get more confused. Why it has to be on my phone and not on the computer?
Frank, can you unmute yourself? Can you mute yourself, please?
Because the phone will be your download.
Vincent, you're muted. You're unmuted.
And then you're logged into your PC. So the part on your phone, I can help you, which is the most important because you're with your authenticator there.
Vincent, you're audible.
But
Look,
come
I
on,
did it.
like,
Vincent, I just have to read it. I just wanted you to explain to me what it is, and that's all. It doesn't matter. If I don't do it, I'll
Guys,
do it. I'll do it.
You're muted. We can hear
Yeah, I'm
Vincent and
trying to call
Catherine.
him.
I don't know.
I'm
You're
going to
muted.
I
call him.
just felt like it's something I did, so I was just asking. So I
Catherine,
figured this out.
Catherine Victorine, mute your phone. There we go.
Apparently not. There is. but-
So if you were about to ask, we could approve this CON, which I think is an excellent idea. Do I have a motion to approve the certificate of need Board of Child Care to the United Methodist Church, Inc., Baltimore County establishment of a residential treatment center?
So moved.
Commissioner Jensen,
Second.
second for Commissioner Boyle. Is there any discussion or question?
So this is Commissioner Bandari. I just have an observation. So is this, so this project is about 920,000 for 4-bed residential treatment center. Each bed is about 230. Is it the normal cost of having each bed, 230,000 or in that range?
Is it normal for, what was the last part of the question?
About the cost per bed? Is this a
Cost per
normal
bed,
cost?
yes.
Right, so that's the cost, the 922,000 is the cost for the renovation of the cottage. It's just for the renovation costs to get the cottage up and running for the program.
Correct. That's a 900 square feet and 4 beds only. So each bed is going to be around 230,000.
I think the commissioner's question, if you know, is that sort of a typical amount of cost per bed or?
I'm not sure, but I could follow back up and let you know.
Thank you.
Thank you. Any other questions or discussion before I call the question?
This is Commissioner Boyer. I just want to say publicly to everyone that this is a need that is felt throughout the community. I have heard from multiple people within my own community of having challenges trying to find a place to put their children so that they can stay safe, especially people who have children who have multiple issues happening at the same time. Many of my friends have had to take their children out of state in order to find the correct level of care. So I think it's wonderful that our state has identified this as an issue, has identified funding for it. And I'm hoping that we'll be able to expand this a little bit more so that families can stay together in the state of Maryland. Over. Thank you.
This is Commissioner Boyle to follow up on Commissioner Boyer's great comments. I think my major question here, I'm very much in favor of this, but my major question is, how do we expand this? And I guess that's something for another day, but it's such a need that this is great, but it's not, it's not going to take care of everybody.
Right.
That may be then a question for consideration at a future, outside of the scope of this one CON. Other things that we should be looking at or considering.
So I think that is a recognized issue. There are 6 RTCs currently in the state. We will be having a presentation by Paul Parker and Lawanda later on in the meeting today that outlines the current status as well as potential to encourage expansion of RTC in the state. It's something that is well recognized, but the challenge of getting new entrants is one that they're going to fill you in on. It's not for lack of trying that we have no more RTCs. And I think this will be beneficial if we defer that until Paul and Lawanda present.
Do you want to briefly add on also that the grant funding for this project does go throughout 2026?
So that's
And we
not just for renovations, that's for operations as well then?
Correct, yes.
And last night, when asked about that, folks in Department of Human Services assured me that if that question came up, that they were confident that additional funding post 2026 could be identified. So I think successful operation has a little bit longer time window than the current current.
Great. Are there any other questions or shall I call the question?
Yeah, this is Commissioner O'Connor. Can you hear me?
Yes, sir.
Commissioner O'Connor, I have a question. What is the average length of stay in this bridge program?
It's in, let's see, it's in the staff report. Hang on one moment for you, I'll tell you. I believe it's approximately 6 to 9 months, Commissioner, but, oh, okay, here it is. So it's 274 days.
So it seems to be fairly grossly inadequate for the number of youths that require this.
Right, and this is also, the Board of Child Care is not the only agency that is receiving funding through this grant. There are other agencies who are receiving funding, but this is the one for this particular report.
All right, thank you.
Sure.
All righty. So on the motion to approve the CON for the Board of Child Care, All in favor?
Aye.
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 Are there any opposed? Mr. COA? Was there, I saw some folks online. Is there anyone you want to introduce from the Board of Child Care?
Oh, right, we skipped over that part. I would like to introduce them. They're here on the call with us today. We have from the Board of Child Care, Nicole Smith, who is the Executive Director, Rashawn Stewart, who is the Director of Special Operations, Zana Blatt, who is the Director of Finance, Terrell Boston Smith, the Chief Financial Officer, Karen McGee, Vice President of Maryland Programs, and also we have with us from the Maryland Department of Health, Mindy Kim Wu, who is the grant sponsor.
Welcome and good luck with this program. Yes, good luck. Agenda item number 5, Maryland Trauma Physician Services Fund, fiscal year 2022. The Maryland General Assembly passed legislation effective 2003 that requires the Maryland Healthcare Commission and the Health Services Cost Review Commission to report annually on the status of the Maryland Trauma Physician Services Fund to the General Assembly in accordance with section 2-1257 of the state government article. The report and presentation slides were included in your agenda packet. Richard Proctor, Chief Operating Officer, will present the highlights of the report and answer any questions in advance of the commission's vote to approve submissions of the report to the General Assembly. Richard.
Good afternoon, Mr. Chairman and Commissioners. I'm pleased to provide a brief overview of fiscal year 2022 Maryland Trauma Fund report to you today. As Chairman Sargent noted, this report is required by statute and brought before you each December for your approval prior to submission to the Maryland General Assembly. The fund covers the cost of medical care provided by trauma physicians of designated trauma centers for uncompensated care, Medicaid enrolled patients, trauma-related on-call and standby expenses, as well as the trauma equipment grant. And the fund is financed through a $5 surcharge on motor vehicle registration and renewals. This report, as previous reports, includes an executive summary, background information, status of the fund at the end of fiscal year 2022, the fund status on a cash flow basis for fiscal years 2020 through 22, and payments to practices for covered services, the Health Service Cost Review Commission standby expense allocation, and the trauma grant program as well. Also included are the administrative expenses, revenue and reimbursement outlook, and developing challenges. I have several slides were included in your packet. I'll just put those up, but I won't read from them. First slide, please. Fund was established by the General Assembly in 2003 to aid Maryland's trauma system by reimbursing trauma physicians for uncompensated care losses and by raising Medicaid payments to 100% of the Medicare rate. Legislation also established a formula for reimbursing trauma-related on-call expenses. Been modified several times since passage in 2003. The most significant statutory changes expanded eligibility for fund payment levels for classes of providers. Next slide, please. The status of the fund, the end of fiscal year 2022. This is located, by the way, on page 4, table 2 of your, or page 4 and table 2 located on page 5 of your report. Collections totaled about 12.2 million compared to 12.6 million in fiscal year 2021 and 11.8 million in fiscal year 2020. The governor's emergency order was in effect in 2020. Fund dispersed about 11.5 million to trauma centers and trauma physicians. Health Service Cost Review Commission incorporated University of Maryland Park allowable cost into their hospital rates effective January 1st, 2022. Fund dispersed about 11.5 million to trauma centers. 1.8 uncompensated care costs total about 1.8 compared to 2.1 in the previous year. Payment for on-call services totaled about 8.8 million compared to 8.4 million in the previous year. And the fund balance ended at 6,700,833 compared to 2,171,071 previous year. This is a result of the General Assembly restoring $4 million to the fund via the 2022 Budget Reconciliation and Financing Act. You may remember those on the commission. I'd like to note for those who weren't on the commission that in 2018, the legislature, through the 2018 Budget Reconciliation and Financing Act, transferred $8 million from our fund to the general fund. Mr. Steffen requested in June of this year that we receive a partial reimbursement back to the fund, and that was successful, thanks to Mr. Steffen's initiative. Thank you very much. And so that's the end of the status of the fund at the end of 2022. Next slide, please. Is the revenue collected and obligations paid in 22, and that's very similar to the first slide, so I won't go over that. I just want to make one note that the Medicaid payments total 280,000 in fiscal year 2022 versus 275,000 in fiscal year 21. Next slide, please. Outstanding obligations. The fund incurred but did not reimburse about $5.2 million in obligations, which are not reflected in the FY22 year-end balance. These obligations result from on-call and standby stipends paid by trauma hospitals from January 2022 through June of 2022, but reported to the Maryland Healthcare Commission after the end of the fiscal year. As in past years, these obligations are paid by the fund in the subsequent year. Next slide, please. Expectations for 2023 and beyond. In FY23, we expect the fund to have a slightly higher balance than this year, based on expectations of lower uncompensated care costs, based on for collection costs for the first 3 months of this year are substantially lower than last year. Table 7 in your report details the anticipated cost in FY 2023. On-call now representing about 3/4, what last year represented about 2/3 of total spending, now has increased to close to 3/4 of total spending. We consider this an issue and will probably continue to increase absent any action. Trauma centers will continue to inquire about increase in the $5 surcharge on motor vehicle registrations and renewals. And level 2 and level 3 centers will receive larger trauma equipment grants in fiscal year 24. That's based on the balance that we closed at this year, which was at $6.7 million. We have a 10%, we're restricted to provide 10% of the balance, no more than 10% of the balance for the equipment grants. Next slide, please. Options for modifying the trauma revenues and expenditures. This is located on table 8, your report. We believe that maintaining reimbursement levels and the funds we believe that we will be able to maintain reimbursement levels and have a stable fund can be maintained over the next couple of years through its current authority. It should be noted that consensus has been a very key factor in the Trauma Coalition campaign to establish Maryland Trauma Care System. We continue to work with the trauma system in that regard. Developing challenges located on page 12 of your report. Over the next year, the Commission will continue to work with Trauma Network and policymakers to examine potential funding challenges in an open, collaborative manner. Just want to refer real quickly to table 8, which was several of the actions that could take place. One was to increase the motor vehicles registration and registration renewal from 5 to 6. And the other is to change the compensation for on-call. And currently, we would like to net out the non-compensated care and Medicaid payments received. That would help in the on-call situation, with the on-call situation. That concludes my remarks, Mr. Chair.
Thank you. Are there any questions?
I have a question.
Commissioner, I have
Brzezinski.
one quick question. This is Dr. This is
I'll do
Commissioner
Commissioner
O'Connor.
Brzezinski first, and then Commissioner O'Connor. Commissioner Brzezinski, go ahead.
Thank you. Page 17 of the report, appendix table 2, uncompensated care payments made. Find it interesting that under one name about halfway down, Mohammed Khan, 10% of the uncompensated care payments went to one individual. That seems disproportionate to what else is listed there. Is there a explanation for that, or is that a name of an entire practice just listed under one person's name?
I do not have an explanation for that, sir, at this time.
Pardon me?
That was what was reported to us, and we have not sought clarification at this time on that.
Okay.
So, Commissioner Kuzinski, I'm sorry, who did you reference?
Mohammed Khan.
Mohammed Khan receives 10% of uncompensated care payments. Seems disproportionate to other individuals listed there, especially in comparison to organizations or large groups listed there.
Yeah, we'll have to defer that.
Okay.
And get back to you on the specifics of that. I'd like to say that's a group, but I don't know that.
Okay.
Ben, can I just ask a follow-up question then? Is there something in terms of this when these disbursements goes out? Is there an oversight that happens in terms of an enforcement action? If there is something that appears, at least some organizational part that takes responsibility for reviewing it, or is it referred on to the Attorney General? I mean, what is it, how is the system set up to avoid abuse? Not saying that Dr. Khan is in any way abusing the system, but what mechanisms are in place?
So thank you for that question. There is of course, instructions on when they can submit a claim for uncompensated care. That's after 2 attempts to collect either from an insurance company or directly from the patient. The individual practices then submit a claim much as they would to an insurance company. We have a contract with Trustmark, which serves as a TPA for some large employers, and they adjudicate claims on our behalf. They confirm the information on the transactions. We did, but haven't done so recently, audit practices on their submissions. We do annually also send a notice to the practices to identify and repay the Healthcare Commission, the Trauma Fund, for claims in which the Trauma Fund reimbursed them. And then in the case of litigation, accidents, for example, there's been a recovery through tort action, and therefore the provider has been reimbursed. So we are the payer of last resort, but we recognize that in some civil cases where there's lawsuits that carry on for several years, that they may not know that there's other opportunities for reimbursements. Those amounts tend to be quite small. Richard and I were just talking about restarting the audit process for both on-call, which is where the bulk of the money goes, as well as uncompensated care, since the COVID pandemic has abated. Visits to practices or more.
Is it possible that we need something a little more structured, a little more formal? I started off my career doing what's called targeting analysis, going through data like this, looking at the patterns in the data that were just statistically unlikely to be random. And you'd have 2 or 3 decision rules. It didn't, it was not a finding of anything. It was simply where you then targeted that your kind of inspector general type staff would start, they'd look there first, and they'd also look if there were complaints and things like that. But it's a way of just sort of using the data you have and you've already collected to sort of look for these patterns, and just to verify that everything's kosher here, that there's nothing that requires. And simply asking the questions sometimes is a good enough deterrent to any kind of questionable behavior. And is it possible that we need something like this here just to assure? I mean, I know it's not a ton of money, but is there at least?
It's not a ton of money, but I think the political ramifications of misappropriation of this would be rather huge. And
just the responsibility of it.
The necessity of maintaining trauma services, as a physician who transfers patients to trauma centers, it is so critical that we have someone there to answer the phone and receive the patient. So yeah, I think I agree with you, Commissioner O'Grady, that some level of formal accountability, analysis and accountability on this would be, I think, appropriate and part of our commission to do so. So anyway, I would be behind anything to that effect.
You know, Ben, I'm not looking to make a big burden for you, but maybe you have good analytic people, a set of analysis through the data with then a referral on to someone in you know, the Department of Health Inspector General or someone like that, that if they decided to take it to the next level, they could do so. But at least we would do our due diligence.
think it's
to
a
make
good-
sure,
I
You
think
know,
it's-
as well,
It's a
money
good
well spent.
suggestion. I think it's a good suggestion for the staff to take away. I put out there also though, one consideration you might think of this is it may not be a state inspector general effort as much as a vendor service. Where for most employer groups, for example, the claims processor will also have a post-claim payment integrity offering where they would identify claims that need further investigation, or there may be recoveries or fraud investigation, things like that. So
I agree.
another
This
piece
is
of
much
this
more
might be to
where we
investigate
are.
what Trustmark does or could do in that space.
Perhaps it would make sense for us to take the issue and think about it in a cool moment about what might be the best way to approach it and then come back with
And
a suggestion.
And Trustmark may be doing some of that already too. So we want to make sure we.
Commissioner O'Connor, I have a question too.
Commissioner O'Connor, I think it's your turn. I know you. Thank you for waiting patiently.
Yes, sir. Thank you. I was just curious, is this compensated care and on-call stipend just for surgeons at trauma centers, level 1, 2, or 3? Is it a requisite to be board certified trauma surgeon? What about acute care hospitals in rural areas that have general surgeons covering the ER for trauma? Is there any compensation for them, or is it just so-called trauma centers?
For level 2 and level 3 trauma centers. At this time.
What about the little general surgeon out in rural Maryland who covers the general surgeon who covers the hospital for trauma, which I think would be quite a luxury for rural Maryland? They don't get this available compensation.
So if I may, I'll answer that. So this was in direct response to the closure of the Emeritus Level 2 Trauma Center in 2002, because Emeritus at that time argued that the on-call stipends that they were required to pay the surgeons and anesthesiologists that are required under MIMS regulations, which designate trauma centers, was excessive for Emeritus at that time. The legislature established this fund, recognizing that others, particularly the level 1s, Hopkins Park, the University of Maryland Shock Trauma, and level 2 Sinai and Prince George's Hospital Center at that time came forward and said, well, we don't have really on-call issues, but we have uncompensated care issues where we can't collect. This was, of course, pre-ACA, pre-Medicaid expansion. So the legislature put together kind of a compound agreement where all of the trauma center practitioners got something. But to your direct question, Commissioner O'Connor, there is no provision for compensating surgeons who take call either in rural or urban hospitals that are not trauma centers. And keep in mind that on the on-call payments, we are actually paying hospitals back for the on-call stipends that they make to physicians, to Dr. O'Grady's point, documented on-call expenses. The on-call stipends that we pay constitute about from 40 to 60% of the total on-call expense that the hospital pays to the on-call physician. So in almost all cases, we're paying a significant fraction, but not all of the on-call expenses.
Right.
On-call with the evolution of practices owned by the hospital is kind of an odd topic because they're all salaried now, but the hospitals insist that they're still on-call stipends for their employed physicians. Hope that helps.
Gotcha. Thank you.
And we do need to move on. I did have one question about the Children's National Medical Center grant, because it says in the back, we can award a grant of up to $590,000. And it seems like every year we award a grant of $590,000. So is that based on actual costs by Children's, or how do we set the amount of that grant? Children's.
Yes, I defer.
That's based on their documented filing to us. And how did that happen? Children's National Medical Center is part of the Maryland Trauma Network. So they were successful. Out-of-state hospitals also have lobbyists in the Maryland legislature. And they were successful in pointing out to the legislature that they too had expenses, since they were not covered by the rate setting system, not reclaimed the district. They were not eligible for some of the benefits that hospitals got through rate setting. So the legislature took that as credible and
They are
require them to support their claim and consider it justified, if you will.
Okay, so that's not an automatic 590. That's they submitted something, their expenses were above that. That's
correct.
Okay. Great. Any other questions or comments before we put the motion in? Can I get a motion to approve the submission of the Maryland Trauma Physician Services Fund fiscal year 2022 report to the General Assembly?
So move.
Thank you, Commissioner Jensen. Can I get a second?
Second, Bazinski.
Mr. Brzezinski, thank you.
Chairman. So just to confirm, we took the general sense of the commission as action to come back and report to you what we plan to do in terms of oversight. Whether we resurrect the audit process, the on-site audit process.
Yes, and next month if you can, just so we don't slip through the cracks.
Absolutely.
Agreed.
I have a question. So what are you going to forward this report as written, or are you going to check in about that 10% real quick?
We'll check in on the 10%, but I'm assuming, can't confirm that, but unless there's some abnormality, we'll send you a message, tell you what we saw. But wouldn't want to.
If it's a group, maybe you need to edit that line to make it clear that it's a group versus just that person's name.
Thank you. We'll confirm that.
Ben, this is Commissioner Bandari. I looked at, there are 5 big players. The rest are very, very small players in this one. 5 entities got the 10% or higher compensation. So maybe just give some update in the future meetings.
Sure.
Thank you.
Yes.
Great. With that, all in favor of approving the report?
Aye.
Aye.
Are there any opposed? Looks like the ayes have it. Thank you, Richard. With that, and with the addendums noted, we'll move on to agenda item number 6, appointment of the chairperson for the Data Release Advisory Committee. As required by COMAR 102505, MHCC staff has formed a Data Release Advisory Committee, DRAC, made up of a diverse group of industry stakeholders and other related interested parties, including but not limited to academic research organizations, consumer advocacy group, payers, providers, employers, and other state agencies. Malit Konjit Solomon will present this DRAC chairperson appointment for approval. Malit?
Thank you.
I hope I'm pronouncing your name correctly. If I butchered it,
You are.
I apologize.
No, you are. Thank you so much. Thank you, Chairman. Good afternoon, Commissioners. As you may recall, the Commission approved the appointment of 10 individuals to serve as the newly established Data Release Advisory Committee at the October meeting. MACC formed the DRAC to carry out the Data Release Authority under COMAR 102505, the regulation approved by the Commission at the end of 2021. The DRAC's responsibilities are to review completed application, requesting MCDB and other healthcare data available for MHCC's release. The DRAC is also responsible to prepare and submit report and recommendation with the administrative support of the commission staff to the executive director. Last but not least, the DRAC is also, if requested, is also responsible to provide advice, consultation, and expertise on issues and questions that may arise in the data application review and approval process. As per Comartin 2505-08, the commission shall appoint the chairperson from among the appointed members. I'm here before you to recommend to the commission to appoint Dr. Elizabeth Simes, the consumer advocacy representative, as the chair of the DRAC. A little bit about Dr. Simes. Dr. Simes has an in-depth understanding of health insurance policy. Through her professional career, Beth had held senior executive positions with various carriers, including United Healthcare, CareFirst, and Evergreen Health. Beth also served in numerous leadership positions within the state and federal government, including serving as the Deputy Director of Consumer Affairs of the Federal Insurance Office at the U.S. Department of Treasury. She also served as the Maryland's Acting Insurance Commissioner, Deputy Director of the Healthcare Access and Cost Commission, and the predecessor of MHCC. And more recently, Dr. Simes served as the president of Consumer Health First, a consumer advocacy organization formed to advise policymakers on the implementation of the ACA, the all-care model, and the total cost of care model. Throughout her career, Dr. Simes has advanced insurance reform initiatives, negotiated regulatory matters, and policy issues from diverse perspectives. She is currently an adjunct instructor of sociology at Anne Arundel Community College and sits on the board of both Mental Health and Association of Maryland and CRESP. Given her familiarity with the MCDB and her expertise in the industry, staff asked the commission to approve Dr. Simes as the chair of the Data Release Advisory Committee. With that, I conclude my presentation and I welcome any questions.
Thank you. I get a motion to approve the appointment of Dr. Elizabeth Simes as chairperson for the DRAC.
So moved.
So moved.
Heard Commissioner Boyle make the motion, and I did not hear who seconded. The second.
Second, Carrie.
Thank you. Any discussion? I'll say I know Beth Simes. She'll do a fine job. That's my comment. Any other questions, comments, or discussion? Great. All in favor?
Aye.
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 Are there any opposed? Great. Agenda item number 7. Financial restrictions on access to organ transplants. A report requested through the Maryland General Assembly's 2022 budget resolution. MHCC staff was asked to report to the legislature on hospital policies limiting organ transplant eligibility. Eileen Fleck, Chief of Acute Care Policy and Planning, will be presenting the staff report. Eileen, please proceed.
Good afternoon, Mr. Chair and Commissioners. So in addition to reviewing the policies, staff were also asked to gather certain statistical information, specifically reasons for denial of access to an organ transplant list, and the number of individuals who may have had organ transplant needs denied or deferred since January of 2018. The request was driven by a concern that financial requirements for organ transplant candidates may be a cause of denial or deferral of care in Maryland. Delegate Shetty requested the budget language based on speaking with Delegate Shetty and reviewing her testimony on a related bill that she sponsored but then later withdrew. Her concern was not driven by constituents in Maryland complaining, but rather hearing stories of kidney transplant candidates from around the country based on other work that she previously done. There are significant costs related to organ transplantation and ongoing prescription drug costs following the transplant. People who have received an organ transplant must take prescription medications to prevent rejection of the organ by their immune system for the rest of their lives. For this reason, there's a strong rationale for evaluating the financial support available to organ transplant patients. The Johns Hopkins Hospital, University of Maryland Medical Center, and MedStar Georgetown Transplant Institute all financially screen organ transplant candidates before continuing with further evaluation, which often involves a lot of medical tests, looking at social support available to the candidates, looking at their ability to adhere to a therapeutic regimen and other factors. Staff reviewed the policies of Johns Hopkins Hospital, University of Maryland Medical Center, and MedStar Georgetown Transplant Institute regarding organ transplant eligibility, and concluded that their policies are consistent with federal regulations that require an assessment of financial support for a patient. The policies did not include any specific benchmarks for savings, income, or assets. Each of the hospitals explained that their financial screening primarily consists of determining if the patient has health insurance, including prescription drug coverage. Patients are not expected to document financial resources available. The hospital also described advising patients on alternative hospitals that would be less costly based on insurance information provided, and potentially advising someone who may be eligible for Medicaid on getting signed up for it. As described by the hospitals, it does not appear that policies are implemented in a way that excessively hinders organ transplant candidates' access to organ transplant waitlists. Staff requested information on the number of potential organ transplant candidates who are denied access to the hospital's waitlist for financial reasons for calendar year 2018 through calendar year 2021 or later if the information was available. 2 of the 3 hospitals could not provide complete information. The University of Maryland Medical Center reported that information on the reasons why patients were denied access to the hospital's waitlist was available for less than half of approximately 3,000 organ transplant candidates evaluated but not listed between January of 2018 and December of 2021. For those where they had information available, they said that only 1 candidate was denied the access to the waitlist for financial reasons. Johns Hopkins Hospital reported that between January 1st of 2018 through July 25th of 2022, it received a total of 10,532 referrals, and 774 patients, 7%, were ineligible for financial/insurance reasons. Johns Hopkins Hospital clarified that category by saying that the reasons were essentially tied to insurance and included that a patient's insurance does not participate with the hospital, that the patient's insurance was out-of-state medical assistance, and that the patient had higher level benefit at another transplant center. It also included the reason patient choice in explaining that category. The MedStar Georgetown Transplant Institute did not provide statistical information requested. Because staff could not obtain complete information on the reasons patients were not added to organ transplant waitlists, we concluded that additional research is needed to provide further insight into whether or not the screening policies could be hindering access to organ transplant waitlists. With respect to patients who've already been added to an organ transplant waitlist at either University of Maryland Medical Center or Johns Hopkins Hospital, staff concluded that patients did not appear to be removed from those waitlists for financial reasons. Information reported by Johns Hopkins Hospital indicated that no patients were removed for financial reasons, only less than 1% for insurance complications. The University of Maryland Medical Center reported that no patients were removed for financial reasons. And again, the MedStar Georgetown Transplant Institute did not provide statistical information. Staff recommends that the state conduct additional research, such as surveying or interviewing patients, both who do and do not pursue an organ transplant following referral. It would be especially useful to include patients who begin the process, but do not complete the process for getting onto the organ transplant waitlist. And that research should focus on the extent to which financial barriers or other social determinants may affect patients' access to an organ transplant. That concludes my presentation. I'd be happy to answer any questions.
Thank you. Let me ask questions first.
So the patients who were disqualified for financial considerations, was there any analysis of those people and any discrepancies in percentages based on racial or ethnic or other characteristics?
So we didn't ask for information on the breakdown. I think University of Maryland Medical Center, like I said, they already kind of couldn't provide the information for about half the people referred. And then they identified only 1 person in the case of that hospital, but then Johns Hopkins, there were more people.
It would be interesting to know, in addition to the percentage of applicants that were denied, the breakdown of those people who were denied. I just put that out there.
It sounds like, I mean, how many people do we know wound up being disqualified for financial reasons versus people that may have just gone away because they couldn't pay and we don't know? Like, did we find that there were people that we're disqualified for not being able to pay, or is it more that we just don't know?
Didn't you say?
So there's in terms of getting on the wait list, what it sounded like is that they're mostly looking at insurance. And that Johns Hopkins Hospital would say that it was really insurance related, but I do feel like there are people where maybe they don't follow up, they don't follow through, or it's a little bit unclear potentially in terms of what the reason was. I feel like there could also be some self-selection in terms of like hearing, okay, here's what you could expect going forward. You have insurance, but keep in mind, you may have to pay out of pocket this amount of money. And maybe people hear that and they don't say to the hospital, that's too expensive, it's not for me, but they're thinking that, and that does cause them not to pursue it. And the hospital doesn't know that for sure. But I definitely feel like that's a possibility where they're not saying that to the hospital, they have insurance, but maybe they just feel like that's the reason.
But didn't you say in your report that Hopkins had rough numbers, 10,000 applicants, and almost 800 were denied for financial reasons?
Yes, but when they clarified that what they mean by financial/insurance complications, they seem to say what that really meant was insurance. Like someone was out of network, someone was, had insurance through another state, medical assistance. And so they're gonna have to almost like get it in their state, their home state. It would be difficult to get it in another state, or they have a better benefit at another transplant program. And so it makes more sense financially for them to maybe go to a different program where they have better coverage.
There may be that, but it's also, it sounds like insurance considerations is a euphemism for financial. I mean, I've got Pennsylvania, so you won't take me. That's kind of, I mean, I'm not just saying that, again, Randy, step in here with your insurance background on this. If you're saying, I'm coming in, I'd like a procedure, and you tell me you're denying me because I have, a bronze package rather than a silver, that's coming down to dollars and cents.
So what it sounded like to me is that if someone has insurance, that's like enough to go through with the process. Like it kind of sounded like they want to know that someone has insurance, that it covers prescription drug costs and the transplant. And that would be enough for the hospital. But then they obviously are letting the patient know, here are the costs you could face, maybe given your insurance, what you might have to pay out of pocket, here's what you need to know. And they're not going to be the ones that say, you need to have $50,000 in your bank account or try to raise it. But a patient would maybe have that information. And that could be a factor in a patient making a decision. But it didn't sound like the hospital is saying no to someone because they don't like their insurance, right? Like it's, oh, you don't have as good of a benefit, but that the patient may want to then decide, okay, I feel like it is best for me to go somewhere else. Or maybe they do sometimes decide, I'm going to go here anyway.
It sounds like we might be, not we, us here at the state, okay, collectively, that we may be muddling a couple of things, like there's, you have insurance, or there's also, you have insurance, but that actually would be better over there, which may not be a denial as much as, or you don't want to go over there. Like, is there a policy at these organizations that say no insurance, no wait lists? Or how does this memorialize? Because I would think that where there's a hard decision, if you don't have insurance, we're not putting you on the list, they would have written it somewhere in a policy that would say that. How are we separating the from what you might get on the soft side is a consultant that talks to the folks and say, you have insurance, we can put you on the list, but if you go on the list over here, you're going to have much better coverage and it'll be much, much cheaper for you, which isn't really a denial exactly. Like, and I would hate to have it lumped in with no insurance, no list. That makes sense.
Right.
And yeah, I think you're absolutely right with the data we've got in front of us. It's not entirely clear what's happening here. One, and two, it would be interesting to know the disparities in the application of those denials. Okay, so if 7% of the people get denied, but 50% of the African Americans get denied, that's an interesting and useful data point that we just don't have here.
Commissioner Bazinski here. This harkens in my mind back to some of the discussions we've had in the health equity work group I was part of here at the commission. And, really social determinants of health are, there's institutional racial prejudices, historical prejudices, but there's also, logistical, you can't make your appointments, you don't get on the wait list. They need to be sure the patients can follow up. And there's a lot of social determinants of health beyond just, race and gender that tend to affect people's ability to get the healthcare that they need at all levels. And, if we are charged with looking at, healthcare equity, this would be a nice little well-defined area to maybe study in more depth, as opposed to healthcare equity across all healthcare settings across the entire state. This could be a nice, definable area to dive in a little deeper, if that's, under our purview as the commission. But I think that from what I read, it doesn't sound like you don't have money, you don't get it. But if you don't have the ability to access the care you need in the way that we see as appropriate, then we're not giving you care. And then the other side that I think the transplant community would talk about is, stewardship of a very limited resource. Harvested organs come at a great price to the donor. And so, it's, there's some, I think, look at the principles of biomedical ethics, there's some element of, social justice and equity in the use of a limited resource. How do you make those decisions? So at any rate, I think this would be a nice, well-defined area for more study, if that's something we're interested in. Just throwing that out there.
Well, this is Commissioner O'Grady again. I'd say that, our prior issue is you have some pretty poor data here and some big lumpiness in who's actually collecting. I mean, Georgetown may or may not have it, but they won't give it to you. Whereas University of Maryland kind of has half the people, and then Hopkins has some. So, I mean, I think we have to know, is there a mechanism here, or do we have to make a recommendation back to the requester to say, this is a big question mark. There may be these other issues about social determinants, about how you define what is a financial denial, but there's big gaps in the data. And is there any, do we have any jurisdictional hook to hang our hat on? Charity care, anything like that, that could actually have some sort of a reasonable data collection that a policymaker could rely on, rather than something kind of Swiss cheese like with a lot of holes in it.
If I could, just to save a little bit, if you look at the last paragraph of the report, that is effectively what we are recommending, is further study and including social determinants in that study. So I just want to make sure that the folks who do that.
But I would move that up, or, I mean, because every study, you come out of a PhD program, they tell you the last paragraph and everything you're going to write is, we need more money, we need more study. So you don't want to be thrown into that category of another researcher just saying you need to do more. Here, it seems to me that we hardly have enough data to stand up straight. It's like you've got this prior problem that you won't have good policy answers until you fix that problem. And I don't know how much time and effort we want to put into this, but at least refer to let these people know this is. And I'm sure you have, I think, but again, underline it or something. Until we know what's really going on out there, there's not too much we can say with strong conviction.
Right, I would say the University of Maryland Medical Center said there was a change to their electronic medical system. And so that's why they don't have the complete data. So it sounded like there was this disruption to it and they should, going forward, have the information. The hospitals are expected to record a reason why someone was denied access to an organ transplant in the medical records, in terms of definitely the people that go through the evaluation process. I'm not sure what might be required in terms of someone that just is referred there and then doesn't really make it through the whole process.
Yeah, thank you.
My comment. Okay. Are there any other comments?
Yes, just one more. We do expect that something, the delegate has indicated she was going to be back. Hearing the commissioner's perspective, if that legislation moves, we would offer an amendment to either give us some authority to gather information on those that don't make the wait list. I think that's where the most significant gap is. We don't know necessarily all that much about people who don't get on the wait list. I do just want to clarify for Hopkins that they did raise the question of, you know, some of the applicants that don't get on are DC Medicaid or Delaware Medicaid, that we're not going to get reimbursed for anything for those. It's hard to absorb a quarters of $500,000 transplant without some ability to obtain reimbursement. So they were pointing, it's my understanding, they were pointing back to their hospitals in their home state. They also, both Hopkins and University, emphasized that they did identify patients that were Medicaid eligible, that took steps to qualify them for Medicaid as part of the process of staging that person for transplantation.
And the recommendation for the additional research, is that going to show up in the executive summary of this as well? It's not just buried in the last paragraph.
Well, I thought it is included. In
I don't want to say
executive
buried, because I know it's an
summary.
official
It's
document, so that is the
It's
recommendation.
at the end of the report.
Yeah,
And it's in the executive summary. I think that the chair and I, our copies were not the ones that I sent out yesterday. But, the new document
Okay.
was an executive.
oh, I see.
Right.
Okay,
So
got it.
I will, after the meeting, ensure that everyone got the copy that I sent yesterday, saying it had an executive summary. I'm gonna set it separate.
Any further discussion? I think I need to take a motion in this case. Do I have a motion to approve the financial restrictions on access to organ transplant? The report requested through the Maryland General Assembly's 2022 budget resolution. So moved. That's it.
So
Second,
moved. O'Connor, second.
Commissioner O'Connor is second. Any further discussion?
Perfect timing. Look at this.
Hearing none?
Yeah, she's next.
All in favor?
Aye.
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 Any opposed? We're gonna assume that all the folks voting are actually commissioners, and I heard none opposed, so it passed.
Mute your phone.
Agenda item number 8, approval of staff's recommendations to accept the changes in the telehealth recommendations report. We enjoyed this report so much last month, we brought it back. The Preserve Telehealth Access Act of 2021 requires the MACC to study the impact of telehealth and develop recommendations on the telehealth coverage payment levels relative to in-person care. Draft recommendations presented at the November 17th commission meeting were released for public comment on November 21. Staff received 11 stakeholder letters. David Sharp, Director of the Center for Health Information Technology and Innovative Care Delivery, will overview the changes made to the final draft report. David, please proceed.
Sure, very good. I think the slides aren't the proper ones. I believe this item, agenda item falls before HB 142, so I don't know.
You know, they're switched in my book, so somebody didn't get the change.
So I can go forward, or we can try advancing forward in the slide deck to the next set.
Why don't I do that? So I already read it's teed up.
Okay. Yeah, so. Are you
Go forward with the, we think that the agenda item that Dr. Sharp is presenting is following this. So scroll through this one, and I think we should come to.
So this is not the in vitro?
No.
We're not in vitro yet.
Okay.
It should say, Ramona should say telehealth study as covered,
All right.
separator slide.
Give me a minute to get there. This one here, telehealth recommendations report.
That's correct. Okay, we're set. Thanks a lot.
Yeah.
So let's advance the slide.
We'll go back to in vitro on the next agenda item.
So, good afternoon, commissioners. Our chair teed up very nicely what occurred last meeting and this meeting. So I won't belabor it, but I would note that the 11 comment letters we received, greatly appreciate the input from the stakeholders. We did find some overlapping of comments, so it made considering their changes fairly easy to do, and we love trying to separate out detail facts from.
This stateroom on the right, the one that's closest to the bathroom.
So Janet, I think you're unmuted. If you could mute, that would be great. Okay, let's advance the slides one, please. Go ahead. There we go. And let's go up another slide. Okay, so at the beginning of the report, we talk about in these two sections, some of the changes that were made, staff proposed. In the background section, it was to expand the consumer views and engagement in telehealth for children and older youths. There were commenters that noted that it's important to point out that telehealth can sometimes be difficult. Youths and children can be difficult patients, and they thought it needed to be called out. In the report section, we clarified that the recommendations do not fully align with the Medicare fee schedule. And we also added what you see in italics at the request of the Medicaid folks, which wanted to make it clear that reimbursement should be subject to the limitations of the state budget. Next slide, please. In the first recommendation slide, just to frame it up for everyone, the two boxes, the box on the left shows what was in the report that we presented to the commission at the November meeting. What's on the right in bold incorporates the changes. In the first recommendation, it was requested that we clarify the use of telehealth for interpersonal consultation and healthcare providers, as well as it includes substance use disorder programs. And you'll see that here in the box noted on the right. So next slide, please. In the second recommendation, we clarified the discretion of use of telehealth and under what circumstances removed, because some of the commenters felt that created the perception of limitation. So we made that change. Next slide, please. On the third recommendation, we clarified that patient consent can be obtained for remote patient monitoring at the time services are provided. And some of the requesters commenters asked that we change the language from furnished to initiated. That sends a bit more of a clearer message. Next slide, please. On the fourth recommendation, we clarified alignment of hospice telehealth services with the profession standard of care. So it made it clear that there could be variations based upon different specialists in providing hospice care. Next slide, please. And then the next slide, on this slide 5, we took the frequency of hospital inpatient nursing homes for telehealth, and we removed that. We then aligned it with any treating physician for services following telehealth visit. Next slide, please. On the key terms, there's 2 slides. Essentially, we clarified at the beginning of the section that telehealth terms, noting the definitions are intended to clarify and not replace any existing definitions in statute. These are changes to call out for reimbursement and coverage, as opposed to what some were thinking is in the health occupation articles. So you'll see that we've struck through certain areas of that in the report. And let's go ahead to the next slide. And then here the same thing, so I won't go into details, but essentially the bold recommendations of the changes. And then the last slide. So here we are, where staff is recommending the commission accept the changes that we proposed. I went through them fairly fast because it was pretty explanatory in the documentation you received. If there are questions, as always, I'm pleased, happy to answer them.
I have a question, Dave. Commissioner Brzezinski.
Go ahead.
Thank you. In my review of the comment letters, I noted MedStar, MHA, the Public Policy Partners, University of Maryland, they seem to echo the parity between access to audio only for somatic care, just as we have audio only interventions for behavioral health, telehealth visits. And the revisions that you did, recommendation number 2, removing of under certain circumstances, does that mean then that essentially gives parity between use of audio only for somatic care as well as behavioral health care, or does that still indicate that additional documentation is necessary to justify the use of audio only, or is there a fail first parameter to use audio only in the delivery of somatic care? A lot of the commenters, did acknowledge that, the attempt to use video assisted communication is a barrier to many people, a lot of disadvantaged people, a lot of rural people, and elderly as well. So I guess effectively, I'm trying to make my case again for, with the support of some of these commenters, that, I would like, as a practicing physician, to be able to choose to use audio or audio visual at my discretion without additional documentation. So tell me what you mean by this recommendation 2.
Sure. So
David, this is Commissioner Bandari. I also had to add one thing. If you read John Hopkins letter, page number 28, they clearly mentioned if these recommendations are implemented, we recommend adding language to the explicitly foregoing any documentation requirement for the clinicians, which means if you think technology fail or physician or patient want, they don't want any documentation on part of physician to say this has happened, because this is a more burdensome documentation on part of physician. As Dr. Buzinski mentioned, I echo his opinion. Actually, I'm glad there are at least 5 entities: John Hopkins, MedStar, Maryland Hospital Association, Public Policy Partners, University of Maryland echoed our concern. Not only that, I spoke to Gene Ransom from MedChi. MedChi also has same opinion that physicians should not need any further documentation, because that can lead to future implication if proper documentation is not done. Thank you so much.
So this is an area where I'll tell you, throughout all our efforts to try to have a balanced approach, where we have found some division. And what we're hearing from are the vocal folks who would rather not see anything related to a process in somatic care that gets you from audiovisual to audio only. There is this silent group that thinks that there should be a process. Now, what we're not doing is stating anything about documentation requirements, because we recognized that there's some concern about, there was less concern about should there be a process, and some mentioned fail first, some mentioned, but the idea is that it's at the physician's or the clinician's discretion how this process unfolds. We did not mention anything about noting or putting it in the medical record. We're silent on that because we understand that, in fact, some of the one commenter specifically mentioned the words air quote notebook. And so we were very quiet about what's required, and it may be just a best practice of the physician in some instances, may not be required at all. There is coding that over time will sort of resolve itself, if you will, around when telehealth is delivered via audio only, when it's delivered via using audio visual. That will, in essence, allow for better future reporting. But the process here today is just a best practice. It doesn't require documentation and a recommendation. We are just silent on that.
Is it possible, David, then we can write what Hopkins has suggested?
So, let's refocus this a little bit, because we had a full discussion of this last time and we voted to adopt this report. And we're back with the report we have already adopted. to address some recommendations by staff to the changes to the report. So additional other changes to the report that are not proposed by staff are actually a different can of worms that we would have to take up. And I'd have to say, I feel like we kind of did address this issue last time, and it's not on the table right now. And it would need a separate motion to reopen that issue. So right now, what we have before us are some proposed recommended changes that we should adopt or reject. And let's move those, I think, first before anything else, if that helps everyone.
But I'm confused about Commissioner Wyszynski's question about what that means. The wording.
I'm sorry, what? I'm afraid I don't understand. Is there, Commissioner Wyszynski, is there an open question about one of the proposed changes from staff that I missed? I apologize.
Yeah. If Commissioner Wyszynski would rephrase his question.
Right, so my question is, when it says at the clinical discretion of a treating healthcare provider, does that imply a documentation of my rationale for that discretion when treating a patient? Or is that simply something that I can decide to do without having to additional documentation? I understand the billing side that David talks about, that if you deliver healthcare via audiovisual or audio only, it could be two separate billing codes. That's a process we're all used to on many aspects of billing for healthcare.
Is this tied to one of the 5 recommendations? Which I apologize. Which one are you talking about?
It's recommendation to Chair Sargent, but to your point, I think you were saying that if it wasn't one that was presented, might require a separate motion.
I see. It's a question about the text that was already approved as opposed to the recommended language. Okay.
Can we go back to that recommendation 2?
Why don't we put that on the screen?
Put that on the screen. Levon, can you roll backwards?
It says recommendation 2 on
Recommendation.
There you go. So what we changed was we eliminated under certain circumstances, and we took out in the rationale section, which is the supporting insertion, any reference to requiring documentation, left it silent.
Oh, is that in the larger report?
Yes, sir.
Oh, so you edited the rationale to remove anything.
Any
You left it
requirement.
silent.
Yeah, yes,
Okay.
sir. We're not referencing documentation.
Okay. That would be very well.
Does that help with your concern a bit? Or
That does.
David doesn't say in the, I read the bigger version also. Is that page number 5 of our package?
Yeah, it's page 5, and
It does not say, what I was suggesting is Hopkins has written very clearly, as Commissioner Sargent, Chair Sargent said, we may need to have another motion for that. Hopkins made it very clearly. If these recommendations are implemented, we recommend adding language to explicitly forego any documentation requirement for the clinicians. I know you said you leave it silent, but sometimes silent does not clarify the facts. Our concern is, MedCai has same concern. This may lead to somewhat confusion also. Providers may not know whether documentation is required or not.
so I yield to the chairman. Do we wish to continue with the changes and then come back to this, or do you want us to talk about it now?
So look, I would put it this way. The staff has presented 5 recommended changes. Why don't we dispose of those? And then if folks have other recommended changes that they think staff should have proposed but didn't, we can take that up after we do these 5, just so we're talking about the same thing at one time. Does that work? Just so for everyone, let's address the first 5 here, and then I guess it's actually 9, but the last one's all seem very.
Do you need a motion so then people can question the motion?
We will need a motion. I was giving folks a chance to ask about their recommendations first, but we will need one. But why don't we do that? We'll put one on the table and then we can ask questions about that.
So I'll make a motion that we accept the recommendations that were presented by staff so far.
Thank you, Commissioner Boyer. Do I have a second?
I'll second that.
Commissioner Jensen is seconded. I have one discussion question, and it's about recommendation 5, where we took out the once every 3 days and once every 14 days. And I can see why the hospital systems physicians would not like those limitations. Here's my question. Why did we have those limitations in the first place? What was the rationale and what are we giving up by taking them out?
So, thank you, Mr. Chairman, for that question. A lot of the recommendations that are in the report align with what CMS had proposed in the physician fee schedules from either 21 when changes were made to support telehealth and have maintained that to the current fee schedule. Our efforts were to align as best we could, so there wasn't this huge departure between what CMS required and what we were proposing. And that's the rationale for why that appeared. We did hear the concern of the commission and stakeholders, so staff proposed taking that out.
Are there any other questions?
Is this about questions about recommendation 5 or subsequent?
Well, no, this is about all of the recommendations staff has made. If anybody has any questions about recommendations, actually, it's actually 12.
12. Yeah, I have a question on recommendation 12.
Go right ahead, Commissioner Brzezinski.
The synchronous and asynchronous. I have concern that expanding this telehealth report and such to asynchronous patient communication is beyond the scope of what is studied and is really a can of worms. From my understanding and a little bit of research on what synchronous versus asynchronous is, such as right now we are in a synchronous meeting, we're all live and communicating in real time. Asynchronous would be email or remote patient monitoring where a doctor would get copies of blood pressures weekly. That does not seem to be what was studied in this. That did not seem to be the intent and purpose of telehealth. In my professional experience, telehealth means real-time synchronous care of patients. I think to bridge into the asynchronous, basically we're making recommendations which will lead to funding and payment for these methods of communication. I think throwing the word asynchronous into this document is beyond the scope, dangerous, and it's going to lead to a lot more issues down the road. And I would suggest that asynchronous be removed and that these recommendations, this report just be held to synchronous communications, which is what I thought the report, the study had reviewed and really what we were talking about.
So thank you. That's a good question. Let me try to explain a little bit. So here again, stakeholders are largely divided. We did not originally include the word asynchronous, but when you think of coverage, thinking of coverage of telehealth is broader than sending a message that it's just synchronous. In fact, the FDA calls out use of remote patient monitoring devices and certain ones that consumers have that patient generated that meets the definition of telehealth. And so some of the commenters expressed concern that by not including it, we may be sending the message that telehealth is just limited to synchronous, and they wanted it to be more expansive than that. And that's how we ended up going with calling out asynchronous. But by and large, those of us, many folks would say that telehealth implies both synchronous and asynchronous. So calling it out just made it clear for everyone under the coverage side of the equation what's good.
If I, yeah, I echo that the calls that I took were concerns about not including remote patient monitoring, and don't want to take a survey of people who are wearing devices, but there's a lot of it that's developing and more to come. That I argue that we probably by taking out asynchronous, going to get a flurry of concerns. It also covers the more nebulous area of chats, which are asynchronous, that are used commonly in some areas commonly used in areas where there may be some sensitivity about talking directly.
And let me ask it this way, in the view of the staff, did you have like asynchronous in mind when the original report was developed and the recommendations are developed such that this is a technical clarification? Because it's really just a example. Or is it, oh, now we've added this at the end and you have to go back and look at what was in the rest of the report because you weren't thinking about it at the time.
So
See the distinction?
yeah, so I would say that we did have it in mind all along, and it was just, we would say it was more implied. And then what we heard from some commenters is that it needs to be made clear. Because what we would have implied doesn't mean someone who was less familiar with it might get to the same point. So it was added just to add clarity.
Well, it's interesting, the studies that you showed with the, number of telehealth visits that have, peaked as COVID peaked and all that you showed last time. To me, those were synchronous telehealth visits using audio and audiovisual technology. And that's what was studied. And that's what, led to some of the recommendations. I didn't hear anything. I don't recall hearing anything of, the email communication or chat communication or remote patient monitoring increase during that time.
So, and we didn't call out specifically in that data either, because typically when we think of telehealth, we're looking at, it's a bundled suite, if you will, of technology and services. We did not differentiate that. That's very true. We did not differentiate that in the analysis data that we provided.
So what's the billing code for me to bill for asynchronous communication with my patients? Because I'm unaware of anything like that. I'm aware of remote patient monitoring codes, but that doesn't seem to be telehealth. Well, anyway.
So we'd have to get back to you if you wanted specific billing information.
And here, Sergeant. So sort of the anecdotal information on remote patient monitoring that I received was that the interpretation of the transmissions by the distance provider, if you will, was done on E&M code based periodic billing based currently on what a payer would permit. So we can delve into that a little further, but to the question of what's the code, well, it's an E&M code that I bill once a month because I or the assistant are reviewing the transmission from the device.
And we do talk just on the edges or on recommendation 3 about allowing healthcare providers using remote patient monitoring to obtain consent. So it is part of the report and then the rationale for allowing it. So it is included, but I understand your point, Commissioner, regarding differentiation. And we thought initially, as we said, it wasn't there, but as Ben noted, we received lots of comments from different stakeholders saying it should be called out to make it clear.
Are there any other questions or comments? That I will call the question on the motion to adopt the staff's recommendations 1 through 12. All in favor? Aye.
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 Is there any opposed?
2.
Like Commissioner Bandari and Commissioner Bazinski are opposed. So we will take that as a passage. Now that I promised that we would talk about other recommendations, this is your chance. If you have seen an additional item that the staff did not recommend, you can make a motion about it at this point. Or have I wandered right off of Robert's Rules of Order? I believe this is the correct procedural way.
Motion to reconsider.
So is that it? We have some motion to reconsider a report or a revised report. So Commissioners Manzari or Brzezinski, I think at this point we would need a motion to reconsider the report with respect to an aspect of it or a recommendation to revise it.
I will do the first.
think he needs, is that a motion to reconsider and make a revision to the report?
Yes, make a revision.
And what is the revision that you would make?
My suggestion is if you look at in our package in page number 28, that's a response from John Hopkins. It's John Hopkins, sports patient choice for audio only care. And in the bold, it says, if we recommend eliminated this specific requirement for when audio only is permitted for somatic care, especially in context of health equity consideration, if these recommendations are implemented, we recommend adding language to explicit foregoing any documentation requirement for clinicians. That's my suggestion would be. I will have Dr. Buzinski also make his comments.
Yes, I'm reading that there. And so do we need to suggest specific language then with this motion? I would second this motion. But does it need to be a motion of specific language changes?
I think it should be, I don't know about specific, I guess specific enough that staff could write it in a sentence, you know what I mean? Like this, does it need to be the exact words?
I got a question.
Yes.
Why wouldn't you include documentation for that decision?
So,
I mean, if it's merely the burden of saying, you know, you have a reason in your mind for going audio only. So all we're eliminating here is the need for you to put that rationale in the medical record. So why not?
Let me explain to you. We are already overburdened with the documentations. You know, there's called burnt out. So physicians are already burnt out with the documentation with all the EMRs. More regulation, more documentation, you have to do it. Less likely physician going to do it. The reason is, if somebody doesn't do this much documentation, it can lead to repercussion in the future. So, you know, they may say, this is a fraud. You didn't put this documentation. So that's one of the reasons many physicians may not tend to do the televisits. And at the end of the day, who's going to suffer? Public is going to suffer. We all want to help.
Let's put a pause in the discussion. I think Commissioners Bhandari and Buzinski, I'll help you out. I think what you're asking is a motion to essentially, if you look at what you pointed from Hopkins, a motion to add language to explicitly forego a documentation requirement for clinicians.
That's right.
That recommendation, is that correct?
That's right, yes.
So Commissioner Bhandari made the motion. Is there a second?
Second.
Second. Okay, we have a motion on the table. Now we'll get to the discussion. Sorry, I'm just trying to clear it out so that there's a record we can all follow. So
appreciate that.
I do my best. So are there any other, I know, and I apologize, Commissioner Bhandari, if you weren't finished, please finish. And otherwise, if there's any additional discussion, this is.
No, what I was saying to Commissioner Jensen's comments was, you know, we already have a lot of documentation to do with, especially with electronic medical records. It's affecting everybody's quality of life, especially physicians. A lot of documentation, a lot of that we call it, really doesn't add to the patient care. More things you add, many physicians may tend not to do that because the reason is they'll say, let's bring the patient in the office. The reason is if you miss documentation saying, well, this was done, it is not in the chart, that can lead to audit in the future, and that can be a problem for the physicians.
So can I comment, sir? So I might suggest, because this is one that we dealt with throughout the study, that you have folks that are for this, folks who are against it. And I see it sort of playing out in leadership here. And that's why we opted to try to split the hair and be silent about it. Because you can't win. We weren't able to find a win because those who feel it's important aren't always physicians. Sometimes they're payers, sometimes they're policy folks, sometimes they are physicians. And those who are against it, as the physicians have noted, is there's concern, and so with Hopkins about, and I use the word notebook, meaning that they're taking on more work, and leaving it silent would allow the physician, the clinician, to make the judgment call. And since this is considered for coverage, this is not changing the health occupation article in any way. It's for coverage. So if your practice says, if we leave it to the clinician can ask these questions or default using their clinical judgment or a request of the patient. That's the process. And you have an established process because that's your internal policy. It's not suggesting that with every medical record you have to update it, although to the commissioner's point earlier, maybe you want to, but it leaves it open. And it is not going to be an easy win because we vote one way or the other today. There's still the other side who are very unhappy that may be vocal if it ends up in legislation in the future. So that would be my comment, sir.
Thank you. Is there any other discussion? I'll share my thoughts on this. I think I don't view this as a recommendation about documentation. So it is silent, and I don't feel that we have analyzed documentation requirements in general, and I would leave it out for that reason. It seems like we're foraying into what should or shouldn't be documented in one specific instance in this report, and I would vote against the motion. For that reason, really, it seems like a step farther than we've gone in depth. Anybody else have any comments, questions, discussion, reaction to what I said?
I'm just, I'm sorry, but I would have to see the motion.
The motion is to, and I'm sorry, if you look at the language.
Page 28 in the report.
Yes, if you look at 28 in the report in front of you, in the middle of the page, the last sentence of the paragraph that starts with JHM supports the patient choice for audio only care. The last sentence says, if these recommendations are implemented, we recommended adding language to explicitly forego any documentation requirement for candidates. That language is reference to the language that's in recommendation 2, the paragraph in recommendation 2. So essentially that would add, the proposal is to add language to the paragraph that's in our recommendation 2, saying that there shouldn't be a documentation requirement for clinicians for somatic care. If I have unfairly misstated anything, please correct me, Commissioner Suzuki and Badari, but I believe that's
I would agree that you did state it correctly. And to me, Commissioner Boyle, when it has a list of 3 reasons why you may use audio only, you know, for technology fail, request by patient, or clinical discretion of treating healthcare provider, then that implies that at some point we'll have to document why we're using it, because there's justifiable reasons for using audio only, as opposed to with behavioral care, healthcare, it's unrestricted. So, and you know, you decide to do a call with a patient, audio only or audio visual, it's equally valid, and you don't have to justify why you're doing that. Whereas with somatic care, there has to be a justification, whether that's my discretion, the patient's choice, or something else.
Dr. O'Connor, I think just the opposite. It gives you so many choices there. It implies you do not need to document why you choose one or the other. It gives you more leeway, in other words, and I'm in favor of leaving it the way it is.
Are there any other discussion? That I will call the question. If we articulate the motion right, we will got it. All in favor?
Aye.
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 Okay, so I got Commissioner Buzinski, Commissioner Bandari, Commissioner Dorton. Who else had aye? Commissioner Boyer?
Boyer Wood.
I'm gonna say aye.
Okay. I've got to figure out how many people this is now. Okay. So I do it.
What motion is for? What's the motion on the floor?
This is the motion to add the language to state that there is no documentation requirement for the somatic care for audio only telehealth.
It's already saying there's no required documentation in the paragraph.
No, it's not saying.
It's not saying that.
If it's not saying, it's not. It doesn't say that.
If you vote
I think
yes
we're
on the
arguing for
motion, it would add language saying we do not recommend any documentation requirements. Something along those lines. Is that correct?
The
So why don't I
Right
just,
now, it's silent.
right now it is silent. Why don't I just do a roll call? Dr. Bandari, you are a yes. Commissioner Boyer, you are a yes. Commissioner Boyle,
Yes.
Commissioner Brumbaugh is absent. Commissioner Bazinski,
Yes,
Commissioner Cheatham was absent. Commissioner Jordan.
No, I'm here.
Oh, I'm sorry. How would you like to
Yes.
vote?
Yes, please.
Commissioner Jordan,
Yes.
Commissioner Jensen,
No.
Commissioner Metz,
Yes.
Commissioner O'Connor,
No,
Commissioner O'Grady,
No,
Commissioner, I think Commissioner Ojikutu is not here.
She's here.
I am here.
Oh,
I say
I-
yes.
Welcome. I apologize.
Thanks. No problem.
I will vote no. Commissioner Wang,
Yes.
Commissioner Wood.
Yes.
Okay, the motion passes. So you will add the sentence.
Yes, sir.
Very good.
Thank you so much for your consideration.
With
thank
that,
you all for bearing with us through this.
Thank you for the engagement. That we'll move on to agenda item number 9.
Thank you, Mr. Chair.
Mandated health insurance services evaluation, health insurance coverage of in vitro fertilization revisions, House Bill 142. Insurance Article 15-1501 Annotated Code of Maryland requires the commission to evaluate the medical, social, and financial impact of proposed mandated health insurance services that failed to pass during the preceding legislative session. Staff received a formal letter of request from the House Health and Government Operations Committee to evaluate legislation that was introduced as House Bill 142 during the 2022 session, but failed to pass. Consistent with Insurance Article 15-1501, it is their practice to have MHCC assess such proposed mandates before considering the adoption of a new mandated service or coverage if introduced in a subsequent session. MHCC staff contracted with Lewis and Ellis, an actuarial consulting firm, to evaluate the considerations of House Bill 142 to revise the current IVF mandate under Maryland law. Tracy Hughes from Lewis and Ellis will now present their findings on this study, and staff asks that the commission approve this report for submission to the General Assembly. Tracy, please proceed.
Thank you. Can you all hear me?
Yes.
Okay, great. Good afternoon, everybody. My name is Tracy Hughes. I'm a consulting actuary with Lewis and Ellis. If you can go ahead and go to the next slide, please. L&E was engaged to address the social, medical, and financial impact of the proposed bill, House Bill 142, which proposes revisions and expansions of the current mandated insurance coverage for in vitro fertilization, also referred to as IVF. Resources that we used for our evaluation included publicly available literature. We performed an interview with a large provider group in Maryland for the IVF sector. We also sent out and conducted insurer surveys to 5 major insurers in Maryland, 3 of which responded. And we also utilized data provided from the Maryland All-Payer Claims Database. Next slide, please. The current mandated coverage mandates coverage of IVF for the individual and large group markets. The mandate is for expenses related to outpatient services when patients have demonstrated a history of involuntary infertility and at least one of the ways outlined in the mandated coverage. The proposed bill would expand this coverage to, in addition to outpatient services, for pre or post IVF procedures, pre-implantation genetic testing, and prescription drugs. It would also prevent insurers from denying coverage because of a genetic carrier status. It would remove an exception allowed for religious beliefs of a religious organization, and it would require coverage be provided if an appropriate healthcare provider determines it is necessary for a list of a few reasons listed in the proposed bill. Next slide, please. Of some background on IVF, it is one form of infertility treatment, excuse me, under the umbrella of assisted reproductive technology. It is a procedure in which the egg and sperm are collected and then combined outside of the body and then transferred into the uterus or frozen for future use. Other forms of ART include intrauterine insemination, or more commonly referred to as artificial insemination, or fertility drugs, which can be used both alone or in conjunction with IUI or IVF. IUI is usually a first step in treating infertility. It has a success rate of about 19%. After 3 to 4 unsuccessful rounds of IUI, a doctor is likely to suggest IVF. A common way under the current mandated coverage to demonstrate a history of involuntary infertility is to have 3 unsuccessful attempts of IUI. Common practice among IVF patients is pre-implantation genetic screening and diagnosis. There is no definition currently outlined under the current mandate or proposed bill for genetic carrier, but providers and insurers that we surveyed and interviewed tended to agree that it is generally a person without signs or symptoms of a disease, but genetically carries that disease and therefore has an increased chance of passing that disease to a child. There are several different wording options of this term genetic carrier outlined in our official report. In cases where at least one parent knows prior to attempting to naturally conceive that they are a genetic carrier, they may bypass attempting natural conception and go straight for to seek IVF so that the embryo can be tested for genetic screening prior to being implanted. And under the current mandate, that kind of case does not satisfy the requirements of showing a history of involuntary infertility. So if coverage is to be provided, it has to be advocated for by the provider on behalf of the patient. Under the proposed bill, this is one of the defined cases where if an appropriate healthcare provider states this is the case, that the patient or patient spouse is identified as a genetic carrier and at risk for fetal anomaly, that coverage will be required under the proposed bill if that is accepted. Next slide, please. IVF success rates have risen dramatically over the past 50 years, from starting at about 6% to now 52%, making it currently the most successful form of ART. The average number of IVF cycles per live birth are around 1.5 for women under 35, but can be much higher for older patients. There are 8 clinics in Maryland. The CDC requires that IVF data be reported. And so the most recent year of data available was 2019. And these 8 clinics that reported for Maryland for IVF services made up 5% of the IVF services in 2019 of the US total, despite Maryland only accounting for 2% of the overall population. In recent history, consistent about 2% of all infant births are the product of IVF. Next slide, please. When it comes to utilization and insurance coverage, the carriers that we surveyed and that responded reported between 0.3 to 0.6% utilization, which is consistent with the data IVF delivery rate of 0.3%, acknowledging that all IVF cycles do not ultimately result in a delivery. Based on the carrier surveys, in the individual and large group market, standard coinsurance for IVF outpatient services is 50%. Some do cover additional items, and these additional coverages are more common in the large group market, since the large group benefits are typically more customizable than in other markets. All of the responding carriers took advantage of the current mandate's allowed limit of 3 IVF attempts per live birth and $100,000. While it currently requires actions, it's not mandated that genetic testing be covered, but it often is after advocation by the provider group, as we learned from the provider group that we interviewed. However, action would not be required and rather coverage would be mandated under the proposed bill language for genetic testing. Next slide, please. When it comes to barriers and disparities, costs tend to be the biggest barrier to IVF treatment. Other barriers include lack of knowledge of infertility treatment options and cultural stigmas. The total cost of one IVF cycle can be up to $20,000 for a non-insured patient and up to $14,000 for an insured patient. And that's just for one cycle. Often more than one cycle is necessary. Infertility services are most likely to be used by married, older, non-Hispanic, white, affluent, and highly educated women than any other group. There is no clear evidence showing that mandated coverage for IVF has diminished disparity rates across race or socioeconomic status. Socioeconomically, it's suspected that this may be due to mandates only regarding privately insureds, and mandates not requiring coverage with no cost sharing, leaving often a substantial portion of the cost still on the insured. Regarding race disparity specifically, studies have looked at equal access subpopulations such as military and found no disparity between non-Hispanic white and Black women, but Hispanic women still demonstrated lower utilization. Next slide, please. For the financial evaluation, L&E used the collected information and data to present low-end, high-end, and mid-range assumptions for each variable that could impact cost. While these ranges are not meant to illustrate 3 separate outcomes, they're just intended to capture the various uncertainties in each assumption and then ultimately provide a range of potential impacts for many potential scenarios and outcomes. Each assumption range is discussed further within our official report. Next slide, please. Our resulting estimated fiscal impact range was between 0.1 and 0.3% of the total Maryland claim costs. But L&E notes that nothing in the proposed bill would prevent or limit carriers from making cost sharing or other benefit changes to non-IVF benefits, which would ultimately mitigate or even eliminate the impact of increased IVF coverage. And that concludes my prepared presentation material. I would like to acknowledge my team, Dave Dillon and Hannah Poole, and we would like to thank the Commission for the opportunity to perform this evaluation, and we are happy to take any questions you may have. Thank you.
Thank you. Are there any questions?
Chairman, Mr. Chairman?
Yes, go ahead. Commissioner
Well, I
Wang.
want to say, first of all, Tracy, it was a pleasure to participate in your group earlier. And I think you guys did a really fantastic job with this report, you and L&E, and it's a really great report. I have some questions, and it's not really about your reporting, but more about some of the details of the bill. You know, number one, I want to point out that the language in the bill seems overly broad in terms of eligibility. You know, requires insurers to provide coverage to pretty much anyone. I mean, if the infertility of the patient is imminent, which is a very vague term that could conceivably apply to anybody, if delaying IVF is detrimental to the patient's mental health, then you're required to offer coverage. And I would argue that being in this business, anybody undergoing this is definitely affecting their mental health. And finally, if delaying IVF is not in the best interest of the patient, then insurers are required to provide coverage to everyone. And I think that's something we ought to take a look at, that it's a very broad set of requirements. There's very little space for denial. And I worry that it'll run up costs. And I worry that those costs are going to be borne by people who don't have a need or desire for the services, lower income people, the Black community, Hispanic community, for the benefit of something that it shows is only 2% of the population. The second thing I want to point out in the bill is that there's, I find it a little troubling. The bill removes the coverage mandate exception for religious beliefs. You know, there are a lot of religious groups out there that have a sincerely held objection to in vitro fertilization, especially involves the creation and storage of embryos. So requiring them to provide coverage not only violates their religious beliefs, it also may expose Maryland and insurance providers to litigation. So I feel like removing that exception for religious organizations may be inappropriate. And my other point I wanted to make was that, you know, it's my understanding this bill was already introduced previously in the previous session and it failed. And I was wondering if you or anyone could speak to the stated reasons that this bill failed to pass and how these concerns might be addressed in any potential reintroduction of the bill to the best of our knowledge. Thank you.
I will just make one.
I had one item to what Commissioner Wang just said. I am just curious. I guess it's just curiosity as to you extend this coverage to unmarried patients. That certainly would, along with Commissioner Wang just said, expand coverage to a lot more people. And I'm just, maybe it's just me and an ethical issue extending this in vitro fertilization to unmarried patient, promoting single mothers and so forth, and the economic impact of that.
Yes, I have a couple reacting comments. Regarding the concern about overutilization, I will just say that we did cite one study that was done in Massachusetts for their mandated coverage. They found that while utilization increased, that it did not result in overutilizations with for patients with low chances of success, for whatever that's worth. That was not our study, but we did find it in the research. And my other comment is that under the current mandate, unmarried patients are already mandated coverage as long as they meet the history of involuntary infertility. So this particular proposal doesn't increase coverage in the sense of an unmarried patient. Those were the two comments that I felt like I could provide some more context to. Otherwise, I'd have to pass to Ben.
Commissioner Jensen.
Yes, I'm not sure if this is for you, Mr. Chairman, or for you, Mr. Executive Director, but could you clarify what exactly is our charge here?
So this is the requirement to conduct these studies at the request of the legislature is spelled out in the health insurance article. And it's existed for probably 20 years. I think it was part of the predecessor commission's duties as well. But we always get these studies when a mandate has failed. Obviously, if a mandate passes, from the standpoint of the legislature, to do this. But if it fails, and typically mandates take a couple of years. So, the fact that it fails first year is not remarkable. And the fact that this is known, the commissions need responsibility on request. You don't automatically do it. We have to get a letter from the chairs to conduct this. And they typically would do it if they anticipate the bill or something similar coming back. And then we get a request to assess the financial, social, medical impact of passing this mandate. We try to do it straight up.
But my question then is, does our mandate include evaluating what's placed in front of us, or does our mandate include rewriting what's placed in front of us?
This particular case, I mean, I think we have, we are hiring actuaries to give us input. I think tweaking with the, generally it has been the tradition of the commission to take the mandate studies conducted by actuaries as the commission's work. This is our assessment of the range of the financial impact.
We have in the past, though, where their commission has a concern included in the cover letter, a statement of that concern. So
Because to me, there's two things going on here. One of them is we're evaluating the legislation as it was presented to us.
Yeah.
And then some of the comments have suggested changing the legislation, and I'm just trying to get a handle on whether or not that's within our.
I would say, correct me, but we're not really, it's not in our remit so much to change the legislation, but we are asked to evaluate under the statute the social, medical, and financial impact of the proposed legislation. So,
All right, thank you.
is that a fair statement?
That's a fair statement, and the cover letter typically includes a statement noting that mandates alone don't have, by themselves typically don't have a significant impact on premium, but the cumulative impact can be substantial. That's kind of common rejoinders to the legislature who might do good things for constituents. They see the gaps in coverage. They're inclined to pass, but cumulatively, more than 40 odd mandates do have a.
Thank you.
Any other commissioners have a question or a concern or follow-up?
I have a comment. I
sir.
mean, you're right in terms of this is not our role to change proposed legislation. It's certainly not our role to change actuarial estimates either. And the estimates have come out. I agree with the notion that this seems a little open-ended, but that's not really our role to say that, to suggest changes in legislation. But the estimates are quite low. I mean, I was surprised at how little of premium impact is happening here. So unless we have some questions about their assumptions or something, I'm not sure what role the commission has here, other than to say, you've written this legislation the way you think you want to. The actuaries have come back and told you it's not going to bust the budget or blow up other premiums in the system. But be careful. I mean, we can say that. I guess I have no problem with saying that, but I'm not sure there's much that we can lay our hands on.
Yeah, I think this is Commissioner Bazinski, we as the commission have, engaged L&E to do their financial analysis. So we addressed one of our charges to look at the financial impact of this. And then I guess we have the opportunity to comment on the, social and medical impact on this as well. I appreciated some of the data that was in the full report that, perhaps with coverage, you would have women accessing this care earlier in their life, earlier in their career, lead to higher success rates and lower complication rates than waiting until their finances and career are well established. So medically as a provider, to me, I see like this could benefit, improve success rates, decrease complication rates. I think the coverage for the genetic analysis is very valuable to help, decrease the risk of carrying pregnancies that, may not be viable or lead to, serious problems. I do echo Commissioner Wang's concern on the social side of it, that, we look at the social impact. I am very concerned about the removal for religious, exemption for religious organization that, if you do create an embryo and find that it's, has a chance of some undesired, perhaps non-lethal, but undesired features, then it would be, terminated, and that would be, considered a loss of a human life for many in their religious belief systems. So I think that, does expose this to more legislation and pushback and compromise the success of this bill, on those grounds. So at any rate, those are my comments. And I don't know how much of that might make into a letter or not, but at any rate, that's.
I have one question about what we've done in the past, Ben, because the religious exemption is not addressed by the actuaries for good reason. I assume that one way or the other is not enough affected IVF things to be an economically important issue, but it is part of the bill. I don't know that we want to take a position on that. Have we ever just noted that that's not part of our analysis?
So I
something
think
like
that
that.
we're delving into not what we were asked to do, which is on its face pretty straightforward, into hypothetically a future bill, which, I think there's a good chance that could come up. In that case, the commission will direct my recommendation. Some of the issues that have been raised to wait till a bill comes out. Would then weigh in on whatever its decision might be. I think the expectation on this is what puts, the three dimensions: financial, social, and medical impact.
Just on a quick related comment, in case it can provide any further context, we do note on page 10 of the report that 2 out of the 3 responding carriers said that there were no insureds, either individuals or groups, that took advantage of the religious exemption. And then 1 of the 3 said that approximately up to 0.2 covered organizations took advantage of that religious exemption. So just to draw your attention to that comment in the analysis and just provide some context.
Thank you. Thank you. I had not seen this. You do have the numbers in there. Does anyone else have any other thoughts, concerns? Why don't we put I don't think I've taken a motion on this. It sounds like we don't have any issues with the report itself. Can I get a motion to approve the submission of the mandated health insurance services evaluation, health insurance coverage of in vitro fertilization report to the General Assembly?
So move, O'Grady.
Commissioner O'Grady?
Second.
Commissioner Boyle. Is there any further discussion? Okay, with that, all in favor?
Aye. Aye.
Are there any opposed? Motion passes. And we'll follow the issue during the legislative session and talk about whether there's a position the commission wants to take. We have to be careful on these because I think we delve into areas where people have very strongly held views on either side. And we do have a role as a supplier of facts that can be used to set the debate on sort of some of the underlying policy questions.
And maybe our role is just to identify that there are strongly held views on this, and that could lead to, unintended sequelae for the legislation.
So agenda item number 10, overview of residential treatment center services prefatory to state health plan update, COMAR 102407. Residential treatment centers are a category of behavioral health facility regulated under the Commission's Certificate of Need Regulation of Healthcare Facility Capital Projects. It has most recently been ranked as a medium level priority for state health plan regulation updating, but it is timely to proceed with updating the policies and standards for consideration of RTC projects given the current environment. Paul Parker, Director of Healthcare Facilities Planning, and LaWanda Edwards, Program Manager, will brief the Commission on this category of facility and the issues to address in the SHP update. Paul and LaWanda, please proceed.
Thank you, Chairman. Sorry, good afternoon, Commissioners. Residential treatment centers are a regulated category of facility under the Certificate of Need program, but it has been very rare in recent decades that we have seen residential treatment center programs. It's a bit of a coincidence that earlier in this meeting, we did have a residential treatment center project establishing a small grant-funded RTC. It's a bit of a coincidence, but we created it by really expediting our review of that particular project because we wanted to align it with the grant award from the Department of Health. So this has not been rated as a high priority for state health plan updates because of the frequency of having to review projects. And what we've seen in recent years is a significant decline in the number of facilities, a contraction of bed capacity. And this is in line with reduced demand by the state agencies for out-of-home placements into residential facilities. LaWanda, it has been tasked with developing a white paper because we now feel we've reached a point with RTCs where it is likely we will be getting some more proposals. We've got a relatively small number of facilities and beds in the state, and we have some problems that are occurring because of a lack of the right kind of programs, I would say, for residential treatment. So we just wanted to give you a quick overview of this particular type of service. You got a little bit of this in the project review earlier today. And you're going to be hearing more about RTCs as we convene a work group and start updating our state health plan regulations early next year. With that, I'll turn the presentation over to Alana.
Hi, good afternoon, commissioners and guests. As Paul mentioned, you got an overview earlier. So all I'm going to say, I'm just going to start and kind of go through this as quickly as I can. But today we wanted to define, oh, next slide, please. We wanted to define what RTCs are, talk about how services are used and paid for in Maryland, and regulating the supply and distribution of RTCs. And it's important to note, although you heard this earlier, that the CON approval is required to establish, relocate, or add beds to RTCs. And as Paul noted earlier, that MHCC staff is working on finalizing the white paper. Next slide, please. So what are residential treatment centers? Again, this was mentioned earlier, but I'll just give a quick overview. An RTC is a program that provides campus-based evaluation and treatment for youth with severe mental and emotional issues. And the average length of stay is about between 12 and 18 months. Youth are ages between 7 and 21, depending on programming at each RTC. Next slide, please. So currently, Maryland now has 6 operating RTCs that include St. Vincent's Villa, Nexus Woodburn, New Directions, Regional Institute for Children and Adolescents, or we refer to them as RICA, in Baltimore, as well as there's a RICA in Rockville and Shepherd Pratt. I had the opportunity over the summer to visit with pretty much all of them except for one, and to talk to the staff who were very excited about talking about what's happening and where they are right now with RTCs. We kind of talked a little bit about also for security measures. You will hear from time to time that some of them are considered hardware secure, meaning that they have special types of locks on doors and windows, and others are considered more with staffing ratios. They're using those to ensure the security of each facility. Next slide, please. So the RTC profile, it gives an overview and it provides for the commission, it's like a snapshot basically of each of the facilities. And as you can see, it provides a breakdown of the demographics of each. For instance, you can see like for Chesapeake, for instance, they serve males only. The centers make a concerted effort, of course, to make all youth feel welcome, including LGBTQ youth. And secondly, something I wanted to mention of the diagnosis it gives us an idea of the type of diagnoses that are coming in and the type of issues that the children are having once they come in. And lastly, something I kind of want to mention here is the discharge plan and how important that is, the aftercare, which is vital to youth transitioning back to family and the community. Step down or community programs are generally a little less restrictive, but allow the youth to continue their care. Next slide, please. RTCs receive the majority of its referrals from these agencies that you can see here. And contrary to some were thinking that the Maryland State Department of Education does not directly place students in RTCs. And while the school system provides funding to the local schools for out-of-home placements, it only refers youth if the individualized education program or IEP team determines a student requires residential educational facility needed. Next slide, please. So here you see in the last 7 years, no, there were 9 RTCs that have closed, reducing bed capacity significantly. And Paul mentioned this earlier, of course, in the last 20 years, there's only been a couple of proposals. One had been withdrawn, and the other one you heard from earlier today that was approved, the Board of Child Care, which we're glad to hear. Next slide, please. This particular slide gives you an overview of the average length of stay that the youth resides in a facility. And you can see, like in 2021, the average stay was about 7 months. Step down programs or discharge programs are vital in reducing these numbers. You can see we did not receive information from New Directions in Woodburn. They just didn't get back to us by the commission deadline. So the next slide. All right, thank you. This slide is the bed capacity slide, and as you can see, this gives you a good overview about the number of beds, licensed beds that each of the facilities have. It's something that is pretty critical and crucial to the RTCs in terms of continuing to provide care. Next slide, please. So what are some of the concerns? Why are we talking about treatment centers right now? These are some of the concerns that the RTC staff shared with me last summer on my visit. And as you can see, hospitals have been inundated with youth from RTCs. Youth are sent to local hospitals when acute care is needed, but they can remain there for weeks and sometimes months, depending on the issue or until a bed is available. One more thing I wanted to say about this is that the importance of the bottlenecks at the hospitals. We found that if you could reduce the bottleneck at the hospitals, as well as reducing the length of stay at the facilities, the RTCs were telling me they would have a better chance of being more successful. Next slide, please.
So this slide just shows you that Medicaid is dominant payer for RTC services. I think this actually may have an error because I think what we're showing here is percentage of total revenue received for RTC services rather than portion of total patients. And as noted in the previous slide, we've not gotten a complete data set of everything we'd like to. That's one of the reasons why we don't have the white paper done yet, but we're in the process of working through some of the data gaps that we have now. Next slide. Next slide, please.
Slide.
I think we put our slide where we're to sleep. Can we have the next slide, please?
Next slide.
Air horn.
Well, while we're waiting, I'll tell you what the next slide says.
Okay.
Thank you.
Yeah.
It should be in front.
It's in front of you.
So responding to the concerns that we've heard from Wanda gathered over the summer and talking with RTC providers, an issue that really stands out, obviously this bears on the project review that was done earlier, is proving Medicaid reimbursement. It's an overarching issue that touches on a number of concerns. We have a bottleneck at hospitals in terms of overstays, as the term is used, both in emergency departments, trying to get a referral of adolescents into RTCs, and also overstays at the end of a psychiatric hospitalization for patients who the appropriate discharge disposition would be to a residential treatment center. Obviously, the RTCs feel like they have some issues with providing adequate staffing and retaining staff. And the reimbursement issue is highlighted by them as a problem. In essence, what we feel is the problem that directly creates these bottlenecks is that we don't have the type of specialized program for higher acuity patients. And that's why we're not getting a receptive RTC industry that's accepting some of these more difficult patients who need to be admitted to an RCC. And then improved financial viability. That's also a concern that we've heard. Maybe a factor in some of the reduction in facilities and bed capacity that we've seen in recent years. And to conclude, next slide, please. Wanted to give you a little bit of the recent background on our discussions of RTCs within the scope of CON. Did a modernization report. It's been about 4 years ago now. And Maryland is one of the few states that actually regulates the establishment, expansion of RTC type facilities under a CON type program. These RTC residents, as we've noted, primarily come through state agency referrals. So the thinking has been that, you know, with this fairly narrow set of referring entities, if we have proper quality assurance features in Maryland, and oversight to make sure that performance is high quality, we need to be concerned about oversupplying the market here, which is one of the obvious reasons why one might have certificate of need regulation. Reimbursement is adequate. Should we have concerns with undersupplying the market? Opposition to deregulation is often based on the idea that we eliminate CON regulation of types of facilities. We may get persons entering the market and developing facilities this type in Maryland who perhaps do not have the kind of track record that we would desire. So the idea has been that, well, you know, you can't point to us turning down bad actors because they don't show up. Certificate of need, its existence serves as a chilling effect on that sort of development. That's certainly what we heard from RTCs when we discussed the idea of possibly reducing the scope of CON, eliminating CON regulation. So RTCs, also the intermediate care facilities for addictions treatment, and then the non-institutional services that we regulate, home health and hospice, were kind of the 4 areas that we focused on as possible areas for deregulation a few years ago. But legislatively, eliminating RTCs was not something that got much play in the legislative session. And with that, we conclude this overview. We'll be happy to try to answer any questions for you.
Thank you. And there's no action item associated with this. This was the background discussion just for the commissioners, in case you're wondering what this means next.
And since we never see RTCs, we thought, well, maybe some of the commissioners aren't that excited.
Are there questions?
Commissioner Brzezinski here.
Yes, sir. Go ahead.
Good. So what is your goal to achieve in presenting this information to us today? What would your desired outcome be from us hearing you both and receiving this information?
Well, in the first quarter of next year, we plan to have a white paper completed, and we're going to convene a work group. And it's nice because we can include every RTC on the work group because there's not that many of them in the state. And so you'll be hearing back from staff on what sort of changes we think are necessary in our state health plan regulations. These are fairly outdated regulations. They had been included in the psychiatric hospital regulations in our state health plan until last year. It was about a year ago. And we had a priority for updating those psychiatric hospital regulations. We did that by creating a distinct chapter just for psychiatric hospital services. We, again, because this wasn't a high priority, we left the older RTC regulations in place. But they really reflect a different situation in Maryland, what existed about 20, 25 years ago. Things have changed quite a bit. We have had actually success in reducing out-of-home placements for residential care substantially. That's why we've seen a decline in facilities. But I think we've now kind of bottomed out, and our expectation is that this could be an area where we need to expand capacity. Certainly we need to try to encourage, this isn't necessarily what CON does, but I think if we get some better payment levels, we think we need to encourage more specialized programming to try to make it easier to move more difficult adolescents through the system. So all we were trying to do here is familiarize the commission with this type of facility and program, because we are going to be delving into it in more detail in the near future.
Very good. Appreciate that.
Any other questions or comments, commissioners? Commissioner Boyer.
I just want to say thank you for bringing this forward. It is absolutely frightening from a parent point of view or a friend point of view to see young adults in extremely vulnerable positions where the parent feels if they step away, their child will die at their own hand. So this is immensely important. I've seen families who have the resources able to send their kids to West Virginia or Colorado in order to deal with this situation, because we just don't have enough facilities here in the state of Maryland. And anything that we can do to help facilitate it. I know there are more and more day-oriented programs for these students, but I've heard time after time stories of parents keeping their kids in the ER for days on end because it's just not safe for them to be at home. And anything that we can do to help this process would be wonderful. I also want to point out that on this list of facilities, they're all in the Baltimore metropolitan area. There's none in our rural areas. And when you are a rural family having to take your child to Baltimore City, that provides even more stress on an already very stressful situation. So equality throughout our state would be a wonderful thing for us to work for. Over, thank you.
Thank you. Any last words? Any other commissioners? Thank you very much for the presentation. All right, Mr. Executive Director, we are at agenda item number 11, overview of upcoming activities, and you also promised to talk about like work groups.
Sure, and we have many work groups. I want to note that several of those work groups have commissioner participation. First off, I want to note that the commission staff can, with the assistance of our Maryland Patient Safety Center, had convened a work group on developing a public awareness campaign for workplace health worker workplace violence. That report, which calls for a public engagement campaign, has been sent to the secretary for his sign off prior to release. But I want to thank Dr. Ig and Teresa Lee for leading that group. A second group, the Healthcare Workforce Crisis Commission, and there probably will be more than another one after the end of the next session because it's a priority, continues to be a priority. Dr. Bhandari is serving on that and actually serves as the chair of one of the data advisory groups. That is continuing to meet. Staff is also supporting the work of that work group. 5 different work groups on data have been convened. I think there's a bit of overlap in the focus on some of the data work groups, and I think Tracy and I, along with Dr. Bandari, are going to try to work to narrowing some of the focus so that they're not stepping on each other's toes. 2 other work groups focusing on long-term care. The palliative care work group did have a meeting last week, and we're in the process of launching a survey to gather input from palliative care providers, which tend to be in hospice agencies, some hospitals, and some long-term care facilities. That is assessing the scope of service, the types of the reimbursement, and the nature of patients who use that service. We're also working to include get some additional focused consumer input into that work group as we move forward with generating the final report to the legislature in the fall of 2023. We also have a work group on small assisted living facilities. That's defined in the bill, the law, as 9 or fewer. We've learned from some of our colleagues that they have different definitions of small assisted living facilities. That Commissioner Boyle is graciously agreed to participate on that work group. And where the end point of that is recommendations on what, if any, additional regulatory oversight ought to be directed at small facilities. We are already detecting some differences of opinion on whether they are subject to the same, the equivalent regulatory oversight that larger facilities are. We're going to tease that out and get to the bottom of it and come up with some strong recommendations that provides for some way for the legislature to move forward. As many of you know, most of the assisted living facilities in the state are actually small. 1,600 facilities, in excess of 1,200 are 9 beds or fewer, according to our numbers. So lots of small facilities, probably in terms of the population. Population is larger, the majority of the population may be in larger facilities, but there's lots of small operators with from 4 to 9 residents to deserve additional protection potentially. And lastly, one of the key objectives of the commission was to define CRISP not only as the health information exchange, but as well as the health data utility for the state. David and his team worked hard on that effort. We have begun to convene a work group that will focus on defining some of the technical infrastructure for dispensers, CVS's, Walgreens, the world, providing information on non-controlled dangerous substance information to CRISP, which is then accessible to clinical community for additional insight into the status of patients. That's got off the ground. We recognize that there's significant challenges, but we think we can overcome them. Everyone is engaged. There's some suggestions of the type of solution we might ought to consider from, as you might expect, various technical firms. We're going to work through that carefully with CRISP and come up with the best solution for the state. And lastly, not a formal work group, but an outgrowth from a work group last year. Legislation was passed requiring that payers and healthcare institutions provide additional information on how to construct a advanced directive. Dr. O'Grady's comments noted, and we have worked out some arrangements where a form and advanced directive information sheet developed by the Healthcare Commission will be distributed by payers and providers, as well as it will be available on our website as well as CRISP. In addition, payers will be directing their enrollees through their portal to the CRISP, what we like to call the electronic platform, also known as a web page, where they can go gather some additional information and then be directed to mydirectives.com. Noted that we want to ease the framework for authenticating patients, so it's not as cumbersome as Dr. Brady reported, and encourage commissioners, if you haven't, whether you want to or don't construct an advanced directive, give us our feedback on what you think of my directives. It's the only certified one in the state. I also would note that the commission will hold a commissioner retreat on January 20th, Friday, January 20th, the day after our January commission meeting, focusing on the strategic priorities of the commission over the next 4 years, first 4 years of Governor-elect Moore's
on my screen, and I'm looking for some indication in somebody's background that the holidays are upon us. And I know that we're all fully engaged and working hard. And if you look at my background, I got nothing to contribute to the cause, but please, somebody comes forward with some indication.
I don't know who that
There
is,
you
but could we defer the holiday background discussion until after the meeting's over?
Yes, I think that somehow crept in here.
Patty Cameron.
And lastly, we will review the legislative process at the commission meeting in January. It will be after the session has started, but there should not be material legislation for the commission to consider in that first couple weeks of the session. So bear with us, the corrections and changes that were made at today's meeting. We will make those changes, and I will share with you the letters that go out on the insurance mandates that accompany the actuarial studies.
Thank you, Ben. So that brings us to the end of our meeting. I want to thank everyone before we adjourn. I want to thank you for your engagement, and I will next see you in January. So despite the fact that your backgrounds have no festive holiday attributes, I hope you all have a wonderful holiday, and thank you to the staff. Thank you to the staff for their support throughout the year, and I look forward to working with everybody in 2023.
Thank you.
Happy holidays.
Happy holidays.
Happy
Thank you.
Hanukkah.
Happy holidays. Bye-bye.
I'll entertain a motion to adjourn.
So moved.
Second.
Thank you,
Second.
everybody. Commissioner Brzezinski, did you have something you want to say?
I said second on the adjournment.
Excellent. Thank you. Have a great holiday, everyone.
You too.
No one's opposed.
No one is opposed.